welcome the presidents of our Lord into the house today. Before we any further, so I'm going to invite Dana, please, the opening prayer, followed by Mr. Wayne Young will do our welcome. Registered today, and today is going to prove to be a very exciting day. Before we kick off into anything, we're going to take the time to welcome the presidents of our Lord into the house today. Any further, so I'm going to invite Dana, please, to come up the opening prayer, followed by Mr. Wayne Young will do our welcome. Registered today, and today is going to be a very exciting day. Before we kick off into anything, we're going to take the time to welcome the presidents of our Lord into the house today. Further, so I'm going to invite Dana,
Thanks in Jesus' precious name.
opening prayer, followed by
All right. Good morning, everyone. All right, let's try this again. Good morning, everyone. Thank you. And for those who are joining us online, I'm hearing the good mornings, so thank you as well. All right, so thank you for joining us for our first hybrid healthcare summit for 2023, as our moderator has outlined. On behalf of our senior executive committee, our product managers, our first line manager, Mrs. Blake McFarlane, and by extension, the Jamaica team, I want to officially welcome everyone, both seated here physically and all those who have logged in online. Today promises to be very enlightening and thought-provoking as we continue to thrive to improve patients' well-being and lifestyle. Please sit back, relax, and listen attentively as our presenters treat us to a buffet of information. Welcome again and have a great day. Thank you.
We are reliable. We are commitment. We are curiosity. We are Sandoz. We are a company where
invite our first speaker up, Dr. Camille Christian, who will be introduced by Mrs. Leslie Woolry-Ferron. For the persons who are online, we're going to say that you can use the chat box and you can definitely put your questions there. There'll be no need for you today to write requests in CMEs. Once you're logged in and once you're in the presentation and answering the pre and post-test questions, you'll be receiving your CMEs today. So I'll now invite Mrs. Leslie Woolry-Ferron to come up and introduce our first speaker, Dr. Camille Christian.
we are reliable. We are commitment. We are curiosity. We are Sandoz. We are a company where patients are at our center. Every day we look for inspiration to create new opportunities so that more people in Central America and the Caribbean have more options to improve their well-being and extend their quality of life. We are accessible medicines with affordable prices for people. We are decades of experience and milestones that have marked the history of medicine with effort and innovation. We are pioneers. We are Sandoz, a Novartis division.
All right, morning again, everyone. Today, this task of introducing one of our guests of honors and our first speaker is a great privilege. We are so lucky that she's with us today, despite her hectic schedule. As a matter of fact, she is on call as we speak. Dr. Carrie Christian-Shelton was born in Ontario, Canada, but grew up right here in Jamaica. She attended the esteemed Campion College and the University of the West Indies, where she graduated in 1997. Dr. Christian-Shelton completed her DM in internal medicine and her residency in 2005, then attended the University of Toronto, where she completed her cardiology fellowship in 2010. Dr. Christian comes to us with a host of experience, having worked at the University Hospital of the West Indies, the National Chest Hospital, and the Kingston Public Hospital, as well as sitting on several boards, including the National Chest Hospital Board from 2013 to 2016. In July of 2019, she was instrumental in developing the first cardiology unit at the largest hospital in the English-speaking Caribbean, which is the Kingston Public Hospital. Dr. Christian is quite the philanthropist, providing medical service in varying community clinics dating back to as early as 2001. Most of her time is consumed with work and home duties, as she's happily married with 3 children. She's a member of the Caribbean Cardiac Society, the American College of Cardiology, the American College of Physicians, and she is the medical director and owner of the Kingston Heart Center, which opened in July 2020. Ladies and gentlemen, please help me in welcoming Dr. Carrie, Camille, Christian-Shelton.
Good, happy Sunday morning to everyone. I'd like to first of all thank the Sandoz team for inviting me here this morning to speak on a topic that I find very interesting, very relevant. I'm sure that, well, this is my disclaimer slide. Before I start speaking. So I'm sure that many of us have been to many talks, many conferences on heart failure. And some people may be like, oh, heart failure again. What more can we possibly say? But despite advancing therapy, we've all heard about the Fantastic Four in terms of, the latest medical therapy for heart failure. When we look at our local population, heart failure still continues to be very prevalent. It is increasing in prevalence. How we manage it is not really very optimal. And so we have to bear in mind, how do we apply all of these, new latest therapies to our local population, especially given the limitation in one of our biggest factors, which is cost. We know the impact of heart failure on a global level. We don't have local data, but we tend to extract from international. In the US, there's over 5 million people estimated to have heart failure, with over 500,000 new cases per year. It's the leading cause of hospitalization, with a 5-year mortality of up to 50%. The lifetime risk of developing heart failure is about 20 to 21% by the age of 40. And the prevalence of heart failure continues to rise. And we look at this data, and our local data is not much further from this. You just need to take a walk in our medical wards at the hospital, and you will see that the leading cause of hospitalization is heart failure. Or heart failure clinics. Every week, we're getting more and more patients. And even though I don't have actual data, I can tell you the numbers are rising. Some of the reasons why this could be so: the aging of the population. We know that, with increasing improvement in survival from other conditions, right? Not just cardiovascular, but even improvement in infectious diseases and, all sorts of other conditions. Then there is improved survival. And so people are living longer. There's a lot of limitations why we can't get local data. Lack of personnel, right? Which is probably our biggest factor. We would love to be able to capture local data for heart failure. We would love to be able to for us to see if this Fantastic Four, if it works for our population. We know that a lot of these studies, Blacks are very underrepresented in a number of these studies. And so there's always that question, how does this apply to our region? We are limited Also, with standardizing the diagnosis of heart failure, standardizing how we do echocardiography, and how we make that diagnosis of heart failure. And so, with all of this in mind, my objectives for today is to, let's focus a little bit on the diagnosis of heart failure. We're still seeing patients who are misdiagnosed, maybe because of limitations, and this causes a delay in treatment. We're going to look at how can we prevent heart failure, because ultimately that's where we really want to get to. How can we prevent the onset of heart failure to begin with? In looking at that, we have to go through the stages of heart failure, how we treat it, the fundamentals of treatment, additional treatments for some coexisting issues. And then there are many centers nowadays that are sort of shifting that language and how we approach heart failure. So let's look at the diagnosis. Recent guidelines have said that the diagnosis of heart failure has to be made with the symptoms and/or the signs of heart failure that's caused by a structural and/or functional cardiac abnormality. And this has to be supported by at least one of the following, either elevated natriuretic peptide levels or some sort of objective evidence of cardiogenic pulmonary or systemic congestion. And this is going to be either like a chest X-ray, echocardiography, or even invasive hemodynamic measurements. So when we look at the diagnostic algorithm for patients who we suspect, so that initial assessment, which is our history and examination, which we all learn from medical school, right? Start with history and examination. But yet, it's still missed, especially in our younger patients. The predominant symptom is the syndrome of decreased exercise tolerance. So people will come in and they will complain of shortness of breath or fatigue in doing activities that they may have been able to have, easily accomplished maybe a year ago, a few months ago, but now they're not able to do so. And many times we see that and we attribute it to many other conditions. Asthma seems to be a very common one, right? Especially in the young. The first thing that we will say is, oh, it's asthma. In older people, we may say, well, you're getting older, so you have to expect a little fatigue and a little, some you're not able to do as much as you would be able to do before. Deconditioning, say, have you been exercising? No, I'm not exercising. Well, you're just unfit, so, don't worry about it. So we have to be able to recognize those early symptoms that could suggest the presence of heart failure. And then there's a syndrome of fluid retention. So some may have, leg swelling. And again, that also contributes to impaired exercise tolerance. And then you may have some persons who have heart failure and they really are not symptomatic, and it is found as you're investigating some other cause, and you just come across, they may have done a routine ECG or a chest X-ray for some other reason, and then there's cardiomegaly, and in further investigation you discover that there is a problem. Recognizing the signs, so there's signs of increased volume, right? So their weight may be going up, presence of an elevated JVP, positive hepatojugular reflex, presence of edema, gallop rhythm, all of these things, crepitations in the lungs, all of these things we need to be able to recognize as symptoms and signs of heart failure. So key to the diagnosis, as I said, so once we have established symptoms and signs, the supporting evidence. And this is where sometimes it can be a challenge, because sometimes the supporting evidence comes at a cost. And many of our patients are not able to afford some of these things. NT-proBNP has become very high up in the diagnosis algorithm. And we know that that's a very expensive test, right? It costs over 30,000, right, in some labs. So that's not something that we can readily do in all our patients. Yes, a chest X-ray is not that expensive comparatively, but it's still an additional cost. An echocardiogram is core to your diagnosis in any case. So if any patient who comes in suspected of having heart failure, they would definitely need an echocardiogram. We also have to remember when we're using BNP that there are other causes that can cause an elevation of your BNP levels. And so we have to bear that in mind when we are interpreting the results of BNP. I won't bother to go through the whole list. So once we have established that diagnosis and we have done our echocardiogram, it helps us to put heart failure into one of three categories. Heart failure with reduced ejection fraction, where the ejection fraction is less than 40%. Heart failure with preserved ejection fraction, where the EF is greater than 50%. And then we have that in-between range between 41 to 49 that we call mid-range or mildly reduced ejection fraction. And it's important to put them into those categories because it impacts how we treat it. Recently, they've added another category called heart failure with improved ejection fraction. And those are for persons who previously had reduced ejection fraction and they have had at least a 10% increase in their baseline ejection fraction, where a second measurement is now greater than 40. And in these patients, because a lot of patients and even other physicians will ask me, okay, so if the EF improves, do we stop therapy? And the important thing in this category is that we are advised to continue therapy because we've seen in patients with an improved EF, over time, sometimes they do fall back down again. So we do not withhold therapy or withdraw therapy once they've reached to this category. So it's important to look at the stages of heart failure. So a few years ago, they came up with a staging system of heart failure. Stage A, stage B, C, and D. However, when we look at how we define heart failure as a complex clinical syndrome with symptoms and signs that result from any structural or functional impairment of ventricular filling or ejection of blood, then one could argue that when we looked at how we defined stage A and B, it was like, well, that doesn't really fit into the diagnosis of heart failure. And so they have sort of recategorized how we label it. And stage A is now considered patients at risk for heart failure. So these are patients who they have never had a formal diagnosis of heart failure. They don't have any structural problems with their heart, but they just have risk factors. So it may be somebody who has hypertension, they're diabetic, they're obese, they have some exposure to cardiotoxins, or they have a family history of some sort of cardiomyopathy. Those are patients who are considered stage A, right? Patients who are at risk. Stage B is now considered pre-heart failure. And those are patients who they actually have structural heart disease. So they may have, left ventricular hypertrophy or chamber enlargement or some sort of valvular disease, but they have never had symptoms of heart failure. So they've never presented with shortness of breath, leg swelling, right? But they just have evidence of structural issues. the core of our heart failure patients are stage C. So once a patient has had symptoms, they fall in stage C. Doesn't matter if they are better and they're feeling good and they're, no longer symptomatic, they will always be in stage C. Stage C, if they are better and they're feeling great, we call it heart failure in remission. Patients who don't necessarily recover, we call it persistent heart failure. And then stage D is advanced heart failure, right? So those are the patients with, end-stage heart disease that need, more advanced management. But the purpose of this talk, I'm not going to go into stage D at all. So our goals of therapy at each of these stages. Stage A, our goal is to modify risk factors, to really make an effort in getting all of these risk factors optimized and well controlled. Our aim in stage B is to treat the risk and structural heart disease so that we can prevent the onset of heart failure. And our goal in stage C and D is to reduce symptoms, morbidity, and mortality in these patients. So it's important in managing these patients to identify an underlying cause. And this is where we fall down locally, because many patients cannot afford all the different tests that you really need to do in a patient who is suspected of heart failure. The most common reason that we most likely have hypertension, ischemic heart disease, and valvular heart disease are probably the top three in terms of how we see our patients. But we do see a few who are presumed genetics or familial, right? Because again, we don't do a lot of genetic testing. And so we tend to just associate it with, because I have a set of family who I see, the father has a cardiomyopathy, the two sons have a cardiomyopathy. And so I just assume that it's genetics, right? So that's how we have to do it. Amyloidosis, which is a very underdiagnosed cause, but we are improving in our ability to both diagnose and treat amyloidosis. Still, cost is an issue, but at least we're moving in a direction that we should be able to recognize this condition. Cardiotoxicity, whether through chemotherapy, drugs, alcohol, right? Tachycardia-induced cardiomyopathy, stress-induced. Peripartum cardiomyopathy, we do see quite a number of cases, but again, peripartum cardiomyopathy is a diagnosis of exclusion. So you have to exclude other causes before we can label it peripartum. And that's where we have a challenge, because many of these other conditions, we can't really exclude it. So we label it as peripartum because it's associated with the pregnancy, but really, we're not 100% sure. And then, of course, there are other causes that we also have to look for. So in the early days, before my clinic became very overwhelming, we captured some of the data in terms of patients that we were seeing. Over a 4-year period, we had just over 1,000 patients, and about 34% of those would have been considered stage C heart failure, and the majority of the patients naturally had stage A and B. And when we looked at the risk factors in the patients, similarly to the data that we see in the Jamaica Health and Lifestyle Survey, where the majority of our patients suffer from hypertension, that naturally was the #1 risk factor that we saw in our clinic. Other risk factors, so cholesterol was about 21%, smoking 15%, and diabetes was about 19-20%. When we looked at the patients who had stage C heart failure, again, majority had hypertension. But it's hard to say it's the hypertension per se that caused the heart failure, because again, we weren't able to do our angiography, to rule out ischemic heart disease. Many patients couldn't afford stress testing. And so even the diagnosis of ischemic heart disease was just made sort of based off of our clinical suspicion. So the accuracy of it, would not be there. But regardless of the underlying cause, if we can recognize heart failure early, improve our accuracy in diagnosing it, then that really is the key to preventing the onset of heart failure. And so we really need to spend a lot of effort and time in managing these patients who are at stage A and stage B. And that's going to be managing hypertension, getting optimal control of blood pressure, managing patients with type 2 diabetes. And there is now an increasing role of using SGLT2 inhibitors in patients who are diabetic and have cardiovascular risk. Optimal management of patients with other cardiovascular diseases, genetic testing, counseling, all of these things are going to be important in the patient with stage A. People who have stage B or pre-heart failure, there are different medications that are categories of medications that we would give to help to optimize these patients. But I think locally, if we can just optimize hypertension, we would help a lot of patients and prevent some of these cases that we're seeing. It's one of the major primary risk reduction strategies for the prevention, not only for heart failure, but even other conditions such as coronary artery disease, MI, and stroke. Recent data and guidelines suggest an optimal blood pressure of 115/75. And there is a lot of physician inertia in getting to these targets. We still have people coming in, they may have a blood pressure of 150/95, and then we're still saying, well, a little high, but there is nothing done to optimize it further. We know that there's a variety of treatment strategies, lifestyle changes, pharmaceuticals that are used in the management. So we really have to make an effort to optimize our blood pressure control, focusing on healthy lifestyle habits, encouraging our patients to physical activity, maintaining normal weight, dietary patterns, and avoiding smoking. What are some of our barriers that we face in optimizing blood pressure? So the first thing is that we have to have accurate blood pressure readings. Now, I tell my residents in, say, our clinic at KPH, when we see, the 140/90 or the 150/90, I say, well, we kind of have to take that with a grain of salt, because if you see how the blood pressures are taken, first of all, they're getting up from 4 o'clock in the morning to get to clinic, they haven't eaten anything, and many of our patients, once they don't eat, they're not taking any medication. They come, they have to stand up in a long line, and then they're hot and they're hungry, and then the nurse will say, okay, next, and it'll sit, and the blood pressure is taken. Clearly, that's not the most optimal way of taking our blood pressure. So we can't use that and say the blood pressure is uncontrolled. So we have to make sure that how we're taking is important. Many of these studies that we look at, these optimal blood pressures, that's not how the blood pressures were taken. They were seated quietly, average of 3 readings, sitting for 5 minutes in a quiet room, and that's how you want to get your reading. And practically, that's not how we do it. And so we have to bear that in mind. Sometimes it may involve doing things like ambulatory blood pressure monitoring to really get a feel as to whether this blood pressure is controlled or not. Because if we inappropriately treat what we think is a high blood pressure, when the patient goes home and they're more relaxed and the pressure has come down, then they're going to go hypotensive. They're going to get dizzy, they feel bad, and they're just going to stop everything, right? And many times we're not seeing that patient again until, a few months, and they just don't take their medication until they go back to the doctor. So we have to bear that in mind. Polypharmacy is another big problem. So you'll have a patient, for instance, who comes to a health center. They go to a hospital clinic, and then they have a GP. And the lack of communication amongst those groups, everybody's kind of giving the patient different medications. I've seen so many times when they come in and I say, let me see what you're taking. And they take out, 2 big bags of medication. And when you really look at what they're taking the same medications, but it's just 2 different names. And they're like, where you got this one from? Oh, I went to, Dr. A and, he put me on this one. And where you got this one? Oh, this was from the health center. And so it's the patient who is now left to figure out what to take from all of these different medications. And then again, it leads to side effects. They don't feel good, and then it just stop everything. Access to medication and cost, that can sometimes be a problem. We have a lot of elderly people who are not able to necessarily go to the pharmacy to get medication. And so that is a problem. Side effects, we spoke about cultural norms, in Jamaica, too much tablets, not taking all of this, right? They don't like to take medication. Plus there's also, we battle with the herbal doctor and the alternative medicine that patients feel that, they're gonna give something else a try. Let's not bother with the tablets. And then, as I said before, physician inertia, right? Where we ourselves sometimes are not aggressive enough in managing blood pressure. So, yes, there are guidelines that will tell us how to manage hypertension. I'm not going to get into this because this is not a hypertension talk. But as I said, also to remember the non-pharmacological treatment, which is equally important to medical therapy. So when we get into class C, right, which is the core heart failure patients, they'll fall into one of 4 categories. So they'll either be new onset, right? So newly diagnosed, patient comes in for the first time, no previous history of heart failure. They may fit into a patient who, yes, came in with heart failure, but they're now resolved, right? So they may either have had previous symptoms of heart failure with persistent LV dysfunction, or they may fit into a category where they're in remission with resolution of previous structural and/or functional heart disease. Now, yes, some patients do recover, but most patients don't recover to the full, 100% that they were before. There's usually some residual abnormality after, which is why, as I said, it's important to still maintain therapy. They may fit into a category called persistent heart failure, and those are patients who still have ongoing symptoms and signs or limited functional capacity, and then they fit into one called worsening heart failures, and those are our end stage, stage D patients, where despite treatment, they are still having worsening symptoms, signs, and functional capacity. So how do we manage these patients at stage C? Early intervention to prevent decompensation. So if we can capture these patients and treat them in the early stages before they actually, decompensate requiring hospitalization, then it would do our patients very good. And we do this with goal-directed medical therapy, outpatient strategies to focus on maintenance of patient stability. So we spend a lot of time with patient counseling and education, promotion of compliance with medication, and for patients who have been recently discharged, discharge planning, right? So we don't want patients to go home and then the next follow-up is 3 months time, right? Because many of these patients, if they're not followed up early, they are right back into hospital within a month. In managing these patients, our goal is to decrease symptoms, improve their quality of life. We want to reduce the rate of hospital admissions. With heart failure, each hospitalization further causes a decline in their quality of life and quantity of life. And by ultimately decreasing hospitalization, we help to decrease the overall healthcare costs. There are a number of different approaches that we take for treating stage C. So lifestyle changes is important, medical therapy, we have device therapy, surgical therapy. The management is definitely a team approach with the patient in the middle. We need the input of several categories of healthcare workers, or pharmacists, or social worker, psychologists, heart failure nurses, dietitians, primary care and cardiologists, all have to work together to optimize the management of this patient. Patient self-management, as I said, is very important. Counseling and education. We teach our patients how to take the medications as prescribed. We teach them how to restrict both salt and limit their fluid intake. We encourage them to stay physically active. We encourage them to get their required vaccinations, right? Something that is overlooked. We teach them how to monitor their signs and symptoms of worsening heart failure. One of the things that we try to tell our patients, like, get a scale, weigh yourself every morning. Once your weight goes up by more than 3 pounds in a day, that's one of the first signs that you're retaining fluid. And then maybe, they may have to take extra diuretics, for instance, to help to offset getting into a decompensation. What are some of the barriers that we face in effective heart failure self-care? So cognitive impairment. So again, we have a lot of elderly patients who may have dementia, Alzheimer's, and they're not able to manage themselves properly, to take their medications properly. Depression, right? Many of our heart failure patients are depressed, and that impacts their ability for proper self-care. You may have patients who, are substance abusers, or just due to frailty. But then there are also social barriers. We know the financial burden. These medications that are very optimal for heart failure therapy come at a cost. Some patients have food insecurities, and as I said, our patients are not taking any medications unless they eat. And I've had patients who have come and I said, why you didn't take your tablet? Well, it says to take after meal, and I didn't have a meal. So they're not taking the medication. Housing insecurity, transport limitations in terms of getting to the pharmacy to get medication, abuse in the home. Sometimes our elderly patients are not being taken care of by their relatives. Low health literacy. So if patients don't know, they don't know how to to deal with certain issues and low social support. How can we overcome this barrier? There have been a lot of programs with public-private partnerships in other areas of medicine that we have started to implement locally, and maybe extending it to programs that can help our heart failure patients, things that have to do with psychotherapy, nurse-led support programs, home health aides, cardiac rehabilitation programs, having registered dietitian and nutrition evaluations, home meal delivery or other food programs, local housing services, and expanding our medication or existing medication programs like the NHF to include some of these medications that are beneficial in our heart failure patients. Maybe getting heart failure as a condition by itself on our NHF program. So looking at actual treatment now of the stage C heart failure. So there are two sides of it. There is symptom relief and there is more drugs that we give for mortality benefit. Symptom relief diuretics. So we typically use our loop diuretics. If loop diuretics don't work, we can add thiazide type diuretics such as a metalazone. Digoxin is also useful in symptom relief. And in patients who are hospitalized, it may actually require inotropes or morphine. But the drugs that we give for mortality benefit, these are the ones that we want to help to extend life. And there are a number of medications that have been used over the years. And we've had a number of trials over the last 20 years that have shown benefit in these groups of medication that have proven to be beneficial in stage C heart failure. Coming out of that are drugs that affect the renin-angiotensin-aldosterone system, of which there are 4. When we look at the pathway system, it affects it in different areas. So you have ones that affect the breakdown of neprilysin. We have ones that affect angiotensin 1 and angiotensin 2. And then we have ones later on that would affect aldosterone. And so our core in utilizing these drugs is important. ACE inhibition is useful because it reduces afterload and preload. It helps to reduce systolic wall stress, increases cardiac output, and it has a very neutral effect on heart rate. It has been shown to reverse left ventricular hypertrophy in hypertension and reverses some endothelial dysfunction in coronary artery disease, hypertension, and diabetes. The drugs that we typically use, most of which are available locally, and we always try to titrate up to the maximal tolerated dose. Angiotensin receptor blockers have been shown to reduce mortality and heart failure hospitalization. There are a number of trials that have looked at or ARBs. ARBs are useful in patients who cannot tolerate an ACE inhibitor, predominantly because of the cough, because it has no kinase inhibition. An ARB, however, has a class 1 level B evidence in terms of managing our heart failure patients. And so it's really in patients who are unable to tolerate either an ACE inhibitor or an ARNI. Drugs that we typically use for patients So candesartan, losartan, or valsartan, and as usual, we try to get to the maximal tolerated dose. In about 2014, the paradigm trial came out, which showed that there was a drug that was the first drug that was shown to be superior to the initial one, enalapril, in benefiting patients with heart failure. It's a combination of an ARB and a neprilysin inhibitor, which is the enzyme that degrades natriuretic peptides, bradykardin, and adrenomedulin. It has been shown to reduce both morbidity and mortality. It reduces the prognostic biomarker NT-proBNP, and it improves the left ventricular remodeling parameters. It's used in patients with chronic symptomatic heart failure with reduced ejection fraction and NYHA class 2 to 3 patients. Again, we start low and we try to titrate up to the maximal tolerated dose. Mineralocorticoid receptor antagonists, or MRAs, are aldosterone antagonists, of which there are 2, eplenorone and spironolactone, and there are trials there that have shown the reduction in all-cause mortality, heart failure hospitalizations, and sudden cardiac death. We don't give it in patients who have a GFR of less than 30, and if their potassium is greater than 5. Drugs that affect the noradrenaline system, beta blockers, have been shown to reduce the risk of death, hospitalization in patients with reduced ejection fraction. It improves the EF, it lessens symptoms, and it does improve the clinical status. The 3, however, that are used are bisoprolol, carvedilol, and metoprolol. So we don't use atenolol for patients with heart failure. So it's important when we're putting patients on beta blockers that we choose the correct beta blocker to place these patients on. Again, we start slow with a low dose and titrate up to maximum tolerated doses. In a patient who may be acutely decompensated, we don't start it necessarily at that time because we know that beta blockers are a negative inotrope. And so we either wait until they're stable, or if they're previously on it, we may reduce the dose. But ultimately, before they're discharged from a hospital, we definitely want them on it. The latest to the group of beneficial drugs for heart failure, the SGLT2 inhibitors, which was discovered as a by the way for diabetes, is that it was shown that it reduced heart failure hospitalization, it reduced all-cause mortality and cardiovascular death. There are a number of different mechanisms by which the SGLT2 inhibitors have been shown to be beneficial in patients with heart failure. The 2, dapagliflozin and empagliflozin, are the ones that are used. There's no titration as it's only 1 dose. And when we look at these 4 drugs, they're all class 1, level A, for the management of heart failure. And they form the core of treatment. But there are other drugs that we can add. So as I said, if they're symptomatic, digoxin may be useful. If loop diuretics are not enough, we may have to add an naltrexone. If the patient has coronary artery disease, we may have to add statins and antiplatelets. If patients have, say, atrial fibrillation, we may have to add oral anticoagulants. If patients are not able to tolerate drugs from the renin-angiotensin aldosterone system, then we may have to add a combination of hydralazine and isordil. If the heart rate is greater than 70, Despite maximal tolerated doses of a beta blocker, we may have to add ivabradine. And then for patients whose iron levels are low, we may even have to add IV iron. So to sort of summarize the principles and pathophysiologic targets of heart failure, there are 5 pathways that we try to modulate, which is the angiotensin 2, norepinephrine, aldosterone, neprilysin, and SGLT. In modulating these pathways, these are the 4 drugs that we use to modulate those pathways: the RNA beta blockers, MRAs, and the SGLT2 inhibitors. And then there are other drugs that may have a role in specific patients. What we choose will depend on the tolerability, it will depend on availability, cost, patient preference, and we always, as I said, try to get them to maximum tolerated doses. It's important to know the drugs to avoid in heart failure. Many of our patients are elderly, they have arthritic issues, and they are placed on NSAIDs, for instance, which is potentially can cause them to decompensate. Diabetic drug, thiazolidine-dione group, is also one that we don't give to patients with heart failure. Heart failure and depression, it's important to recognize, as I said, depression affects the management of heart failure, and we should be screening for these, screening our heart failure patients for depression. Shifting the language in heart failure. So many centers nowadays are trying to shift how we look at heart failure. Instead of saying heart failure clinics, we say heart function clinics. And that helps us to understand the barriers that we face to medication adherence, and it helps us to better tailor heart failure care. So on a typical ward round at a hospital, we may say, oh, a 45-year-old man who comes in with decompensated heart failure, secondary to non-compliance with medication. And instead of saying that, we would say a 45-year-old man who presents with decompensated heart failure. Potential barriers to adherence include the cost, polypharmacy in the setting of a recent job loss. So immediately that sets a different tone to how we approach that patient. So we don't just berate the patient, oh, I never take a tablet. We will look at the reasons why they're not taking their medication and try to address each of these issues. Despite knowing all of this, there's still clinical inertia on the part of physicians. We may say, well, the patient is stable, so why am I, increasing the dose of the medication? Why change the course of therapy? Or the patient only has mild symptoms. It may be an inconvenience for both the patient or the physician, or it may just involve more work and you just can't bother. But these are some of the threats to patients who would benefit from newer therapies. So to summarize, I'll just use this as one of my summary slides. It kind of goes through what we have spoken about, the definition of heart failure, recognizing the different stages, how we classify heart failure, the fact that language matters and that we are shifting our approach to how we even look at heart failure. Sometimes physicians look at it as a cancer, right? When we look at the mortality, the high mortality, and how progressive the disease is, it's sort of similar to how a cancer is. And so it's important to optimize and control risk factors, specifically in stages A and B, to delay the progression to more advanced stages. We want to up-titrate medications to maximally tolerated dose to improve mortality and morbidity. And it's a team approach to ensure compliance with both lifestyle changes and medication. These are my references, and I'll take any questions.
All right. Thank you. Thank you so much, Dr. Christian. I'm going to invite you to stay at the podium. You will be able to see some of the questions that were fielded from online on your monitor, and I'm asking you in the interest of time to see if you can answer the best 3 questions, and I'll allow somebody from the floor, if you have a burning question, we'll reach out to you so you can ask that question so those online can benefit from it as well. All right? Okay, we can read it for you.
Yeah.
If I see a patient who is severely hypothyroid or severely anemic with signs and symptoms of heart failure, would the BNP be elevated? Although the heart is a victim of the existing condition, is it still called cardiogenic?
Right. So I gave a list of I mean, I didn't dwell on it, but there's a list of conditions that do cause an elevated BNP. And so, yes, in interpreting a BNP level, we have to be aware of the different things that can cause an elevated BNP. But what we tend to look for is the actual level, because different things would cause an elevation to different degrees, right? So if you have a significantly elevated BNP, then you would say it's more likely due to a cardiac cause as opposed to one of the other causes.
All right, thank you very much. Any questions from the room? We don't want our online persons to bad way up, you know. Anybody from the room have a question? If you raise your hand, I'll give you the microphone. Here we go, right here.
Good morning, everyone. Thanks, Dr. Christian, for that presentation. Coming from the primary care perspective, I've seen quite a number of persons who may be diagnosed as heart failure, being sent back to the primary healthcare service for follow-up. But in terms of audits, I've seen sometimes that they are not put on beta blockers, or as you said, they may be put on the wrong beta blockers. Is it possible for you to work with the Ministry of Health and Wellness to create like a guideline or a policy document to guide the management of heart failure? I heard you mention that you'd want to have heart failure on the NHF and some other things, but I think if you had like a document, a policy document to clearly show how to properly manage it. As you said, it's a cardiac cancer, so that would prevent the progression of it to really end stage.
Yeah, definitely. That's an excellent idea. I mean, we definitely need a lot more out there for management of heart failure. As I said, we also need to be capturing our numbers because just in our clinics alone, I mean, as I said, we definitely are seeing an increased number of patients, and it's not just elderly, young patients as well. So it definitely is a significant burden in our setting, and improving the knowledge of it in the primary care as well will definitely be of great help.
So I see 2 questions here. That's not true, there are like 22, but 2 that we'll select. From Dr. Bandara Kaur. Dr. Christian, what are your views on home blood pressure testing and using that to assess the need for and effects of treatment?
I'm very big on home blood pressure testing. I encourage all my hypertensive patients, if they can, to have a machine at home. I tell you, if you have a relative abroad, beg them go into a Walmart and pick up one for you. Because it's important. As I said, a lot of patients, again, especially in the public system, where the blood pressures are not necessarily taken in the most optimal way. Home blood pressure readings is what is going to kind of guide us as to what the overall control is like. If their home blood pressure readings are perfectly normal, and we are only seeing the elevated readings, in office, then we know it's just maybe a white coat hypertension or just the way that the blood pressures are taken. What I normally advise the patients, though, is to bring in their machine and just kind of compare, just to make sure that we can believe the one that they're having at home, because we know that all blood pressure machines are not equal. Right? Sometimes little wrist ones, and sometimes they're not even doing it properly. The wrist ones, and they're holding it down, and they are saying, "Oh yeah, man, I'm getting good readings," but they're not doing it properly. So there has to be that sort of validation before you can believe the home readings.
Dr. Christian, excellent talk. Do we still do blood pressures, left arm, right arm, sitting and standing? Because I once picked up a patient who turned out to have a cardiac abnormality, 120/60 on the left arm, right arm sitting 160/120. Right?
Right.
So these things still happen, and then you do it sitting and standing. If it's just the first visit, fine. It's not every time you see the patient.
Yeah, yeah, and that speaks to, as I said, how we are doing blood pressures. And really, in a busy clinic, and I have hundreds of patients waiting, we're really not, measuring blood pressures ideally, because something like doing it on both sides, sitting, lying, sitting, standing, all of that are proper ways of doing or measuring blood pressures. Initially, at least, right? Yeah, definitely.
So we want to say thank you to Doc. Please give her a round of applause. Wonderful presentation. We'll try to share all of the questions from online with Doc, and we'll see if she can answer them, and we can email them to you afterwards. All right, over to our moderator for the day, Mr. Beecher.
All right, thank you again, Dr. Christian. All right, so just a bit of housekeeping issues. For those persons who are here and they're wondering where the restroom is, so once you exit here and you turn left, the restroom will be right on the right-hand side, so you can discreetly go out and use it if you need to. And for those of you who might need something to eat as well in-house, we have coffee break around the back. You can discreetly go and help yourself in between the presentations, all right? All right, so at this time, I'm going to invite Miss Jan Watkins to come up and introduce our second speaker. But for those of you in-house who are wondering what the Wi-Fi password is, just log on to the Courtly's internet page, and it's Sandoz for the username and the password, okay? So Jan, please come.
Thank you, Christopher. Good morning, ladies and gentlemen. I am so pleased to be with you this morning and to have the chance to introduce our speaker, Dr. Adedamola Soyibo. Dr. Soyibo comes to us with a great depth of experience and knowledge in his field. He has spent close to 20 years serving in diverse roles ranging from Medical Officer of Health at St. Anne's Bay Hospital to Senior Lecturer, Consultant Internist, and Consultant Nephrologist in the Department of Medicine at the University Hospital of the West Indies. Though medicine is a passion of his, Dr. Soyibo is quite the writer as well, contributing more than 25 full paper publications in peer-reviewed journals, such as Kidney International, which is the official journal of the International Society of Nephrology, and the West Indies Medical Journal. Though he contributes so much to the medical field in this fashion, he has also managed to perform the duties of assistant editor for the West Indies Medical Journal for over 12 years. Dr. Soyibo, continues to make his mark within his chosen field of nephrology. A real-life kidney superhero, so to speak. He wears many capes, namely as Chief of Nephrology in the section of nephrology, hypertension, and renal transplant, as Head of the Organ Transplant Unit at the University Hospital of the West Indies, and as Technical Director at the Caribbean Institute of Nephrology. Dr. Soyibo has also served as Chief Coordinator of the Jamaica Renal Week Symposium and Assistant Chief Coordinator of the Annual Conference of Nephrology and Hypertension between 2008 and 2014. Dr. Soyibo would take the knowledge and experiences gained and in true philanthropic fashion would cross our Caribbean waters to found and coordinate the Tobago World Kidney Day in 2011. Philanthropy is a common denominator in Dr. Soyibo's professional career. His brainchild, the SciArc Research Institute, a Jamaican nonprofit charity, has been providing medical philanthropy for those in need for over 5 years. Dr. Soyibo, a true scholar, has disseminated the education he has gained with great benevolence. His boundless knowledge base and wide range of world-class experience, as well as having academic training responsibilities since 2009, has made him a master in delivering workshops and seminar presentations, and he has indeed been a staple at CME since 2011. It is safe to say that our kidney superhero comes to us well-versed in all things renal. However, I wouldn't attempt to test him on a basketball court either, as he is also an acclaimed sportsman and has received Outstanding Achievement Awards for basketball in 97 and 98. Without further ado, please join me in welcoming our speaker this morning as he presents on the topic, Renoprotective Effects of the Angiotensin Antagonist in Patients with Nephropathy Due to Type 2 Diabetes. Our own real-life kidney superhero, Dr. Adedamola Soyibo.
Thank you very much for that exaggerated. Wow, I was like wondering who she's talking about. But I must say, though, that's very eloquently put together. You should send me a copy of it. Well, so I must say thank you very much for the invitation. And it's good to be here to share knowledge. I'm going to try not to bore you with too much biochemistry for this morning, but I was intending to, but then I thought maybe. So my role this morning is really just to look at the renoprotective effect, why we advocate for RAAS blockade in persons with type 2 diabetes. But it goes beyond just type 2 diabetes. You just heard a nice presentation by Dr. Christian that talks about heart failure and the role of ACE, ARBs, or renin, angiotensin aldosterone axis blockade in heart failure. So these drugs have mechanistic requirement to be used in persons with hypertension, heart failure, renal disease, those who have proteinuria. You need to consider, because it is activated in most conditions. So sit back and relax and let's see. So I'm required to show this slide, but it wasn't said how long it's supposed to be there on display. So long-term protection in type 2 diabetes with RAS blockade. And the idea is just to reduce renal complication, really, and of course to make people live longer. So everybody is always dazzled by the fact that the prevalence of diabetes continues to increase worldwide. And we're part contributors to it. And I don't know what we're going to do, but the incidence continues to increase. My mother-in-law always says, I'm going to put people like you out of business. She is about 76. She still does very well. Her HbA1c is better than mine, and her cholesterol is also better than mine. But we know that the prevalence of diabetes continues to increase. But what is even sad about it is that the level of control or target, whether using HbA1c of less than 7, well, in this actual study, or if you want to use HbA1c less than 6.5 in a pre-selected population, the control is terrible. And also, 2 diabetic patients out of 3 who have diabetes will also develop hypertension. I can say that anybody who have or who has kidney disease will eventually develop high blood pressure also. So CKD begets hypertension, and hypertension also can cause CKD. So you need to look out for those, regardless of the initial cause of the kidney disease, whether it's diabetes, whether it's lupus, whatever it is. Once you get kidney disease, you're going to develop hypertension. Now, if you look at incidents of what is the actual cause of problem with CKD patient, what causes them to be sick, what causes them to be in hospital, you realize that myocardial infarction or cardiovascular disease are the main risk factors. Now, I always try to look at the positive side of life. So my patients come to me and they get to CKD stage 5 and they need dialysis. And they're like, so that's the end? So it's like a diabetic person coming to you for years, and then you tell them they need to go on insulin. And they get all depressed and panicking, like, oh, that means it's the end. There's no reverse. It means it can't come back. Well, for the CKD patient, I simply tell them that, listen, it just means that for you to arrive at this stage, you survived all the complications that could potentially happen. Stroke, myocardial infarction, heart failure, all of those things would have you will have survived them to get to this stage, because the reality is majority of them do die of cardiovascular risk factor even before they get to needing dialysis. And this slide is showing you some of the drivers of myocardial infarction, stroke, and heart failure. Although we're talking about the renin angiotensin aldosterone axis, but things like HbA1c control, so that's also still important if you want to make a difference in a diabetic person. Systolic blood pressure, LDL, physical activity, and then somewhere in the mix of things, if you can spot it out for those persons who have a ring on their fourth left side finger, you also realize that marital status also affects your likelihood of developing all of these things. Now, what drives this is really has to do with renal disease, coronary death, and coronary artery disease. Those are the main drivers for cardiovascular disease in type 2 diabetics. Now, if you look at persons with type 2 diabetes, and the excessive cardiovascular risk is also attributed to development of hypertension. So if you have high blood pressure with diabetes, then your mortality and morbidity is also increased because of the presence of hypertension. And blood pressure control becomes even more difficult once you start to get other comorbid problems. So if you have diabetes with hypertension, if you have diabetes, if you have high cholesterol, all of these things become more difficult, either because of polypharmacy or the fact that there's drug-to-drug interaction, or the patient just really get tired, Some people will tell you, I take 10 medication in the morning, 5 in the afternoon, and another 7 in the evening, So when we do TDS dosing, like hydralazine, for example, so if I put a patient on hydralazine, 100 milligrams TDS, which means they will have gone through ACE, ARB, CCB, beta blocker, and then you have them on hydralazine. They're going to take that, and then God forbid that the pharmacy decides to give them 25 milligram tablets, so they're going to take 4 for the day. So, we have to be cognizant of these things that will affect, patients' outcome. And then if you bring it closer to home, in the Jamaican Health and Lifestyle Survey, which I like to show because that's the most recent data, the most current one, we have high prevalence of type 2 diabetes. And what happens also is this: if you look at the level of control of those persons who are on treatment and those who are actually controlled, it's abysmal. And the same is for hypertension, the same is for dyslipidemia. So we need to do a little bit better. If you have a diabetic patient, these are some of the things that you need to do in terms of evaluation. So the patient comes to you, they have diabetes. The recommendation says what? You need to evaluate for diabetic nephropathy, you need to look for eye disease at the time of diagnosis. So you need to do all of that. Risk assess the patient, because what's the main concern? The main concern is cardiovascular risk. So you need to risk assess them for cardiovascular risk factors. Then you need to sit down with the patient and talk about the drugs that you're going to use. Then we need to plan follow-up, right? And follow-up does not necessarily mean with you. Follow-up is with the dietitian, follow-up with the food specialist, follow-up with the eye doctor to see, exercise. So there are so many things that you need to do. We heard about heart failure, and at the University Hospital, we have a heart failure clinic, although, I'm going to take Dr. Chris's advice. Maybe I'll throw it to the guys. Maybe we need to start changing the way we label these things so as to take away some of the stigma. We have a kidney clinic at the University Hospital, but we also have a nurse-led CKD class where the patients can come to have questions asked about these things. So you give the patient information, you empower them so that we set up a cycle that works well for the patient in the long run. So what is the pathophysiology? The main driver is hyperglycemia. So we need to control glucose. So hyperglycemia will lead to hypertrophy and subsequent thickening of the glomerular basement membrane. I promise I wasn't going to bore you with this, but just understand that hyperglycemia, persistent hyperglycemia or glycemic excursion, so the more time the patients spend in that high glucose range, typically greater than HbA1c of 7, it's going to lead to a whole lot of changes within the glomerular basement membrane. It's going to affect the blood flow of the kidney, and that will result in microalbuminuria. Once microalbuminuria starts with hyperfiltration, this is the beginning of diabetic nephropathy. It's like asking Usain Bolt to run the same speed of 100 meters in a marathon. By the time he passes maybe 450 meters, he's going to start slowing down. So any hyperfiltrating state of the kidney means there's problem to come. So we need to abate that. Also, this whole glycated product, this HbA1c itself, accumulation of HbA1c leads to not just cytokine release, but it also forms the basis of biochemical chain reaction that affects kidney regulation. And that also has effect on the eyes, autonomic system, on the vascular smooth muscles, the endothelium. So that gives you more reason to have sort of like an immune response state in diabetic nephropathy. And also glucose, if you remember patients who present to you with diabetes, they can tell you that sometimes, I know when the sugar is high, they talk about what, the eyes or the vision getting cloudy and stuff like that. It's because of sorbitol, that mechanism that happens in the eyes, the same thing that happens in the kidneys. And all of this now results in depletion of the good thing that you need for vascular smooth muscle integrity. And so that will lead to changes in the glomerular capillary pressure. Glomerular capillary pressure is what is responsible for your filtration. So it's responsible for, how much waste product you're basically excreting from the kidney. So the derangement in this polyol pathway will now cause increased oxidative stress. And of course, when you have increased oxidative stress, then that's going to lead to kidney damage. Hyperglycemia also still continues by affecting protein kinase C. And now we know protein kinase C is one of the key enzymes in vascular smooth muscle integrity. So which, of course, will also increase your likelihood of developing diabetic nephropathy. So if we were to summarize, and I think this is probably one of the MCQ questions, there are some of the factors that will affect the pathogenesis of diabetic nephropathy, meaning if you have diabetes, are you likely to develop diabetic nephropathy? Yes. So if you can check any one of these, then you're likely to have it. So if you have persistent hyperglycemia, meaning your sugar is not controlled, if you have hypertension, if you have dyslipidemia, if you have albuminuria or proteinuria, if you're Black, okay? If you have genetic predisposition, so if you have parents who's had type 2 diabetes and they develop diabetic nephropathy, chances are you're also going to develop diabetic nephropathy. If you smoke, anybody who smokes, smoking affects not just cancer and those things, it affects your smooth muscles. And if you have anything that affects smooth muscle integrity, it's going to affect flow. And that will also cause a problem. And of course, unfortunately, as we get older, the kidney ages also. So let's talk about this guy. So as time goes on, we talk about, the RAS system and what it does. And I'm going to show you a slide at the end of a publication that came out last year, towards the end of last year, 2022, that now challenges what I'm about to tell you. So, which means when I'm finished telling you all of these things, then we need to be on the lookout for what is coming and what may possibly change. This is medicine, okay? So everybody knows renin-angiotensin physiology. And these are the key things that are responsible. We have angiotensinogen, we have renin, we have angiotensin 1, we have angiotensin 2. Then we also have the receptors, AT1 and AT2 receptors, and their role. So you probably would have seen this in the past. So we have angiotensinogen, which is acted on by renin. Angiotensinogen is coming from the liver. And then you make angiotensin 1. Angiotensin 1 is now converted to angiotensin 2 by ACE, which is produced from the lungs. Then you make angiotensin 2. Angiotensin 2 now also stimulates aldosterone production and will act on the 2 receptors. Now, when it acts on the receptors, at the level of the kidney, you have sodium reabsorption. So if you start to reabsorb sodium, you can understand what's going to happen. Water follows. You have increased volume, so you're going to have hypertension, salt-driven. If you have predisposition to heart failure, that's going to make matters worse for you. And then on the other hand, at the vascular, a smooth muscle aspect, you're going to have increased vasoconstriction. If you have increased vascular tone, that's going to increase your total systemic peripheral resistance. So your blood pressure is also going to go up. And that will lead to hypertension. So that's just the basic mechanism of it. But when we try to now make it a little bit more biochemical and try to incorporate all the possibilities that can go wrong, what you realize is angiotensin 2 is actually going to be responsible for some of the things that I described with hyperglycemia, and that is dysfunction in your glomerular basement membrane, and that will lead to proteinuria at the top. Okay, starts off with microalbuminuria and then progresses to macroalbuminuria. Angiotensin 2 is also going to cause inhibition of nitric oxide, and we know nitric oxide is a very potent vasodilator. So if you have inhibition of nitric oxide synthesis, what's going to happen? You're going to have increased vascular tone, and that will affect a lot of your blood vessels. Now, angiotensin 2 also has an effect on the matrix of a lot of cells, so like the brain, the kidney most importantly, and that will lead to extracellular matrix production. So which means that we distort the function of that particular organ. And then we also have induction of chemokines, and chemokines, I have 1 or 2 slides that will tell you about TNF alpha and or some other chemokines that affect diabetes. So activation of angiotensin 2 goes beyond just the sodium reabsorption that we speak about and the vascular tone increase. So these are some of the other hemodynamics or some of the other issues that happen with activation of renin. How does aldosterone come into all of this? So activation of your RAS system along with potassium is going to cause activation or production, increased production, this is the glomerular of the adrenal cortex. So you're going to have increased aldosterone production. Once aldosterone production increases, it's going to cause a whole barrage. It's going to affect potassium excretion, it's going to affect sodium retention, it's going to affect some other chemokines, endothelial dysfunction, and all of this now we cause some of the things that we perceive clinically. The patient with a stroke, patient with a renal dysfunction, patient with coronary artery disease, and patients with developed hypertension. So when we are thinking about activation of this system, it goes beyond just kidney and blood pressure increase. And these are some of the function of aldosterone, right? Endothelial dysfunction, inflammation, and it causes proteinuria, it causes fibrosis. So much so that now we're looking at inhibition of aldosterone pathway for treatment, not just heart failure, but also persons with chronic kidney disease. So this is the schematic diagram that just gives you an idea of the interrelationship between angiotensin and at the end, how it causes glomerular and tubular interstitial disease. But these are some of the key factors that you see: extracellular matrix degradation, right? Increase in cytokine production, inflammation. So all of these put together is what is going to lead to what we perceive clinically when we do a urine dipstick on the patient. And this is also now incorporating what you see at the level of the AT1 receptors and AT2 receptors. So once you activate angiotensin all the way down here, what you're going to get is hemodynamic vasoconstriction at the level of the AT1 receptors. And then you have the non-hemodynamic factors that also affects sodium water reabsorption, is increased aldosterone synthesis, is increase in TGF beta, increase in extracellular matrix. So all of these things are going to lead to AT1 receptor, or also activation of the AT1 receptors. And then on the AT2 receptor side, you're going to have these hemodynamic changes, which is vasodilatation and reduction in blood pressure. So there's some benefit and some deleterious effect of both receptor being activated. And then this gives you just like a overall diagram just to see the relationship between RAS activation and the effect on the AT1 versus AT2 receptor. Now, this slide probably couldn't figure out where to put it in the whole scheme, but I think it's important that we understand, if you've never seen this slide before, the relationship between what we see at the level of the kidney, which is albuminuria, as a risk factor for cardiovascular disease. So at whichever level, moving from 3 to 30, which is the range of microalbuminuria, all the way up to 300, which is the range of macroalbuminuria, you can see there's a linear relationship between albuminuria and cardiovascular disease. So anybody with albuminuria should be taken seriously. And if you have heart failure with albuminuria, your risk is also increased. And then we have the good GFR. So as your GFR falls, your cardiovascular risk also increases. So we need to know about that. So when are we going to use angiotensin receptor blockade in renal disease? Inhibition of ACE eventually will lead to decreased formation of angiotensin 2 and aldosterone, so you can inhibit both. This will potentially develop vasodilatory effect of bradykinin. ACE, we use it, treat hypertension, reduce proteinuria, yada, yada, yada. Remember what I said. The last slide is going to contradict some of these things. Just pay attention. Drink your coffee if you need to drink coffee to stay up. We're also going to use ACE inhibitors in diabetic and non-diabetic kidney disease. Okay, ARB blocks your AT1 receptor, leaves your AT2 receptor active. So that leads to some kind of augmentation of the good effect of AT2s, if you remember the areas of AT2, ARBs do not inhibit bradykinin breakdown. So let's jump into some of these good old drugs that we tend to use. What is the effect of the ARB losartan on renal and cardiovascular outcome in patients with type 2 diabetes? So this is a placebo control, right? So we're looking at losartan versus placebo in type 2 diabetic person, and some of the markers that we use, which is going to be standard for most of all the trials that you're going to encounter, is either doubling of serum creatinine, progression to ESRD, reduction in proteinuria, but this particular one looked at these two. And what they found was there was a significant renal benefit in patients with type 2 diabetes and development of excuse me, and the development of diabetic nephropathy using losartan. Everybody uses losartan, right? What about irbesartan? Irbesartan in diabetic persons. This now is a double masked randomized placebo study, and they use amlodipine, amlodipine, irbesartan, and then they have controls. They use their blood pressure target at 135/85, which means you can use other medication to try and get the blood pressure to target. Okay, this is just trying to prove one thing. We keep the blood pressure the same for everybody. So you want to see whether the effect of the drug goes beyond just blood pressure control. Yeah? The endpoint is looking at doubling of serum creatinine again and progression to end-stage renal disease, and they looked at mortality. Baseline proteinuria versus CKD progression, early changes in proteinuria versus CKD progression, and the effect of treatment on CKD progression. So everybody understands graph. So you can see that those persons with different levels of proteinuria, so you have those with 1 gram, you have those with more than 2, you have those with as high as those with nephrotic range proteinuria. Okay? What do you find when you use irbesartan, amlodipine, and when you compare it to placebo? What you find is there's a reduction in proteinuria for all of this as opposed to the placebo. So your 24-hour urine protein follow-up significantly is reduced when you compare it to placebo. Now, if you were to tease out this, then you might say, well, Dr. Soyibo said, what's the difference between irbesartan and amlodipine in this particular study? Now, looking at proteinuria changes by 12 months, and you can see those with 50%, more than 50% or less than 50% changes. And you can also see there's a significant change. And this starts to tease out by less than about 10 months. You start to see changes or differences in the level of reduction in proteinuria. You start to see changes in the level of proteinuria. Now, when you look at the other mortality outcome, I will show you those slides later on in terms of, stroke and cardiovascular event, there is not a much difference in those, but you see the effect on the renoprotective nature of angiotensin receptor blockade with irbesartan. Now, this study is use of combination. So this is just to sort of highlight the whole notion of combination single pill, right? So when they use one drug alone, you see the reduction, both systolic and diastolic. When you use the second drug, you see the reduction. However, if you use a combination, you get a better reduction, and also what you end up with is a side effect profile that is less. And in this particular one, we're talking about irbesartan and amlodipine in this particular study. So, looking at this other study that looks at cardiovascular risk factors and disease progression and cardiovascular event, this is sort of summarizing most of the studies that you probably will have heard about or you will have been spoken to about. And this is the IRMA study, okay, iSearch. And then we have the Sylvia study. And if you go further down, you will see the inclusive study, IDNT, which are some of the studies that most people will be familiar with, and to look at the final pathway of death. So, what are the cardiometabolic risks for all of these patients? Impaired glucose tolerance, hypertension, obesity, and dyslipidemia. What will cause the progression of the disease? Endothelial dysfunction, cardiac and vascular remodeling, again, one of the key functions of angiotensin 2, and also fibrosis. So which of these studies now are going to give you a better outcome in terms of cardiovascular disease protection, renal failure, peripheral arterial disease, stroke, AF, and heart failure with, and I'm not sure what the PS4, or systolic heart failure. I guess that's the old nomenclature before everything was revised. So IDNT, which is irbesartan, gives you benefit for heart failure. The active gives you benefit with atrial fibrillation, and iReserve gives you benefit with heart failure, with this systolic heart failure. In terms of death, not sure, exactly which one of these studies actually translated to death mortality. So you can have sort of like a picture of all of the studies using ARBs and the effect on cardiovascular event and eventually death. So this is heart failure with preserved ejection fraction. I don't think that's the way they write it now, but nomenclature has changed. So this is the IDNT and the IRMA study. So the IRMA 2 study looked at those persons with microalbuminuria, whereas the IDNT looked at proteinuria and progression to end-stage renal disease, and they all both looked at cardiovascular morbidity and mortality. Get them early, in the early stages, to use the right drug. So which means in a diabetic diabetic patient, when you identify that they have proteinuria or they have hyperfiltration, you should consider RAS blockade from the get-go. All right, so irbesartan in patient with type 2 diabetes, irbesartan diabetic nephropathy trial, and end-stage renal disease. So this is what this program is looking at. Can we prevent and can we protect the kidneys? And as you can see, if you're using low dose or if you're using the maximum dose, there is still significant benefit with relative risk reduction of more than 70% for these patients. So we can use the drug, especially when we speak about proteinuria. Yeah? Now, going back to renal which is losartan, either 50, maximum of 100, with a primary endpoint looking at double creatinine, ESRD, or death. We had a 16% reduction. The mean follow-up was 3.4 years. Okay? When you look at the IDNT, using irbesartan, that range that I showed you earlier on, or using irbesartan versus amlodipine, what you find is a reduction of 20% in the IDNT looking at placebo, and 23% when you compare it to amlodipine. Although, you know, statistical significance is attained, and the follow-up years is even shorter for this. So what's the effect of using a drug like irbesartan? So there's a graph of, you should probably get a hold of it, of antihypertensive and their true picture of blood pressure control over 24-hour period. You know, we're talking about home blood pressure earlier on. You know, I advise my patient do morning, afternoon, and evening. It's not just to tell you alone the level of control, it also gives you an idea if they have 24-hour control. You know, so if they take their blood pressure in the morning, everything is fine. By the time they come home in the evening, blood pressure is super high. You probably need to consider maybe the drug that they're taking is not giving them that true 24-hour blood pressure control. Irbesartan gives you, whoa. Sorry, what did I do? Go back? Yes, thank you. Okay, yeah, so I'll just continue from there. Well, I just showed you also that they delay progression of nephropathy. When you use it alone, when you compare it to CCBs, the incidence of peripheral edema is less. Now, not much alteration in metabolic profile, especially when you compare it to your diuretic. So, you know, the hyponatremia, hyperuricemia, if, you know, there's not much when you compare it. And it helps with LV, left ventricular hypertrophy regression. And then on the other side is you're gonna see the effect of amlodipine. It's not on this one. You see the effect of amlodipine. So if you combine the two of them, you know, you might get better effect. So when you look at blood pressure lowering assessed by automated blood pressure monitoring, 12 weeks of irbesartan with hydrochlorothiazide, which I, as a nephrologist, probably don't use unless it's absolutely necessary. And you can see that in terms of control blood pressure for 24 hours, you see a nice control, not just in the 24-hour blood pressure. Sometimes we can delineate in a patient that has daytime blood pressure that is controlled, but nighttime blood pressure that is uncontrolled. So if we do the ABPM, we'll be able to know whether the drug is giving the patient full control over 24 hours. But as you can see, the irbesartan gives you that protection along with hydrochlorothiazide. And this is the IAD study, and basically it's irbesartan, okay, 150 milligrams, and then they compare it to irbesartan amlodipine. After 5 weeks, they maximize the dose of irbesartan in both combinations without changing the dose of amlodipine, okay? And then they look at the primary goal at 10 weeks. And of course, we have an idea what the primary goal will be, okay? Now, I put in a few other studies that compares other drugs, so a head-to-head comparison. So those are the ones that are going to be coming up. So it's just going to be like a summary of it. So continuing what the results found is double of serum creatinine was less in the irbesartan group compared to the amlodipine, statistically significant. The risk of ESRD was less in the irbesartan group compared to amlodipine group. That's the p-value. All right, maybe if you make it more people, maybe it will be or not. And there was no difference between the three groups in regards to death. So we have renal protection, irbesartan. We have cardiovascular protection, but in terms of, progression to ESRD, but in terms of death, there was no difference between the three groups, which kind of, makes that a little bit not so cute, not so cool. This one is looking at angiotensin blockade versus ACE in type 2 diabetics. Okay, so this is comparing telmisartan to enalapril. And just to quickly summarize that, after 5 years, telmisartan was found to offer renal protection comparable to enalapril. So in this study, they were both equal. I see this guy walking up like. And then in this one now is looking at losartan versus enalapril. 1 year study, and what they found was enalapril. So patients treated with enalapril or losartan experienced significant reduction in urine albumin excretion, and that was also statistically significant. Now, this is the study that I was telling you about. This came out just in April. This is just me, going through, and I saw it this morning, and I thought maybe I should put it there just for provocation. So basically what they did, this is a meta-analysis of all the randomized clinical trials. That was like over almost 30,000. Narrow it down, end up with 46 studies at the end of it. And basically we know that the guideline says use RAS blockade first before you start to consider anything else. With persons with diabetic nephropathy, diabetes with proteinuria or any proteinuric state. So when they did was they looked at all of the study. First, they did the RAS blockade inhibition versus placebo, and they compared them, looking at to see whether there was any benefit. And at the end of all of it, believe it or not, they did not find the additional benefit when you compare RAS blockade using ACE ARBs versus using any other antihypertensive drug. Yeah, there was no there was no difference. So basically what they're trying to say is this: if the person has high blood pressure, put them on anything. Just control the blood pressure. And they made their recommendation that they're not sure, because it now raises the challenging question as to whether RAS inhibition deserves the first place therapy in management of diabetic nephropathy. So you could take a picture of this, not because I want you to go and read it. You can now start to look for correspondence, because people are going to start responding to this. Now, when you look at all of the trials, there was a lot of trials, but there were some key trials that were not included. Okay? There were key trials that were not included, and there were trials like Advance was not included, but there were other trials included that had perindopril base. So that definitely begs for more, insight. So at my next presentation, that has to do with anything with this, once anything comes out new, I will tell. Sir, my summary slide is missing. There should be a summary slide after this one, before I thank you. But nonetheless, the summary of it all is, one, understand that diabetic patients have increased risk for cardiovascular disease. I don't know if it is still said or if it is still believed that having diabetes is equivalent to having a previous myocardial infarction. So if you treat persons like that, you will put them at a medium. Where did that come from?
It's hidden on your PowerPoint. The slide is hidden.
Okay.
Right, so I have to help you here. There you go.
Thank you. So what I was trying to say is with the type 2 diabetes, in terms of increased mortality and morbidity in these persons with kidney disease, using RAS blockade is highly recommended. Yeah, unless you want to look at the slide just before this one, and then you want to challenge it, which is fine. Persons with type 2 diabetes, associated cardiovascular risk, which increases once they have CKD. So also remember that. So they have diabetes, increased risk. If they have CKD either by proteinuria or GFR, that risk also goes up even more. If you have a reduced GFR or you have presence of albuminuria, these are also risk factors for further cardiovascular complication. Now, ARBs, especially irbesartan, reduces the incidence of proteinuria and the progression of diabetic nephropathy. So you should consider that. And the benefits in prevention of diabetic nephropathy goes beyond just the blood pressure control, because I showed you studies where the target blood pressure is the same, but they still had some significant benefit. And that is the end of my presentation. Did I make it 45?
Thank you so much. All right. So let's see if we can get some questions to you, Doc. What is the protocol regarding renal impairment? Patients are sometimes given long dates for follow-up in the primary care. Hence, the risk of disease progression is very high. Should all patients living with diabetes, hypertension, be referred to the dietitian to modify lifestyle practices?
So that last part of that question is a resounding yes. You need to refer them for lifestyle. If they can afford it, you need to refer them for what you call, it's like a targeted exercise protocol, meaning they're not just, you don't just send them to go and exercise. You need to exercise with somebody who is trained so that they can motivate it. There's a term that they use for it. I can't remember the term. So you need to refer them for that also. Now, that question about what's the protocol for follow-up? For protocol for follow-up, if it's just CKD aspect of it, depends on whether they're stage 1, stage 2, stage 3. If you're stage 1, stage 2, 3 to 6 months follow-up is good. But if you have CKD secondary to diabetes, you can't stick to the CKD aspect of the follow-up. You have to look at the diabetes control for the follow-up. So if the diabetes is not controlled, then you probably need to bring that back a week later or 2 weeks later, depending on what your target or what you're trying to do. If their blood pressure is not controlled, you can't stick to the CKD protocol. Also, because if their blood pressure is not controlled and they have evidence of ongoing target organ damage, you're not going to bring them back in 3 to 6 months to find out their blood pressure has been uncontrolled. So there's so many things that affects what timeline should be given. Now, in the primary care setting, and the same happens even in my hospital, is the fact that if you were to follow protocols for everybody, you probably see like maybe 100, 200 patients in every clinic visit, which obviously is going to affect the quality that you also deliver. That does not negate the need for emergencies in between. There's some patients you might have to see next week in the clinic because there's something going on, if they have hyperkalemia or if they have hyperglycemic emergency. That will also affect that. But the protocol is very difficult in the primary care setting. Now, in the private primary care setting, you can use the protocol based on whether there's CKD, stage 1, stage 2. Once they get to stage 4, stage 5, 1 month follow-up for those patients. If they have diabetes and their diabetes is relatively controlled, HbA1c is our target, LDL is our target, then you can bring them back in every 3 months. But if any one of the parameters are not controlled, then the patient needs to come back earlier than later.
Thank you so much, Doc. So I think our last question will be from the room. However, a question is here online. Will the presentations be available afterwards? Yes, they will.
Thank you, Dr. Soyibo, for an excellent presentation. It was
Thank you.
really very good and well delivered. Congratulations.
Thank you.
As again, I'm talking from the primary healthcare point of view because I'm a consultant in primary care. It is important, based on what I'm hearing from you, blood pressure control seems to be a cardinal point. If that blood pressure is well controlled, it will reduce the nephrotoxic effect, it will reduce the heart failure effect, everything, preventing heart failure and everything. So I think that's a big take home. What I find in primary care is that, especially for the diabetics, most of them are not, their blood pressure control is poor. And I think that is what is fueling the raise in heart failure, like what Dr. Christian spoke about, the increased numbers at your clinic. So if it is that we were to treat them at that goal of 130/80 or less, I think that is what would help a lot. What I'm finding also is that even with the elderly, many times the control is a little bit lax in terms of their blood pressure control as well. So I think that's what I'm getting as a take home. Try to optimize the patient, whether it is for the blood sugar, but the blood pressure is a big indicator. And that will prevent a lot of the long-term sequelae, the kidneys, the stroke, the heart failure, everything. What you said though about that last study, the controversial one, I'm still inclined to stick with the ARBs and the ACEs because of the cardiovascular protection as well. So
and I agree with you on that, 100%. Let me just say that.
And then even so, I'm thinking also, even despite what is said there, I think that the ACE and the ARB should still be first line, based on the effects to the other organs. But I think blood pressure control seems to me to be the underlying thing right here now. That must be good. It will protect the patient from a lot of long-term sequelae.
Yes, definitely. And don't forget the glucose control for the diabetic person. It's also important.
Ladies and gentlemen, please say thank you to Dr. Soyibo for a wonderful presentation. A lot of questions, but unfortunately we don't have enough time to take all of them. I think we'll hand over now to Mr. Beecher.
All right, thank you so much. Thank you again, Dr. Soyibo. Excellent presentations thus far from Dr. Christian and Dr. Soyibo when it comes on to management of hypertension, especially those who are suffering from heart failure from a Jamaican perspective. And now Dr. Soyibo going in on irbesartan. And just want to remind you that Sandoz, we pride ourselves on 100 years plus of history, and we have one of the most robust catalog of cardiovascular products on the market. We do have our Safebull Candesartan and Safebull HCT, especially for those patients who are suffering from heart failure. And of course, we just spoke about the effects of hypertension, especially as it relates to diabetes in particular, and the end-stage renal protection that irbesartan can give. We do have our Tensiba and Tensiba HCT, and also those patients tend to be dyslipidemic. So under the trifecta of things, hypertension, we do have our Rosustar, especially to add on therapy for those patients who will need that statin therapy. And one of the latest products that we have under our cardiovascular portfolio right now is our Divenis, especially for those patients who will suffer from venous disease, venous insufficiency, acute hemorrhoidal attack. We have our Diasmin and Hesperidin Divenis 500 milligrams available island-wide, both in the public and the private sector. And of course, we do have clopidogrel Sandoz still available. So at this time, I'm going to ask Sam to run one of our video presentations that we have on the Sandoz portfolio.
We are quality. We are efficacy. We are safety. We are Sandoz. Leaders in generic and biosimilar medicines, their safety and efficacy are equivalent to their reference medicines, but at a more affordable price. Through comprehensive comparability tests, they have demonstrated to be safe and of the highest quality. We have a portfolio of approximately 1,000 molecules and multiple presentations available per year, where every alternative combines science and ethics within reach of our patients. We are pioneers. We are Sandoz, a Novartis division.
All right, thank you so much. And so I know that some persons are indeed enjoying the coffee break, but I'm going to take the opportunity at this time to welcome our next speaker. So I'm going to ask Mr. Freitas to be on standby. So we have spoken about our cardiovascular portfolio, and now we're going to switch things up. We're going to invite Mr. Christian Freitas to come and introduce our next speaker, Dr. Kiri Bridgewater.
Good morning, everyone. It is my distinct pleasure to introduce to you our guest speaker, Dr. Kiri Bridgewater. Dr. Bridgewater hails from the vibrant island of Trinidad, her official place of birth, but moved to Jamaica in her formative years, where she developed a keen interest for the sciences. It is with this passion that she pursued her medical degree at the University of the West Indies between 2006 to 2011, receiving honors in surgery and internal medicine and a distinction in obstetrics and gynecology. It was during this degree that Dr. Bridgewater discovered her love for women's health care, and she promptly proceeded to do her postgraduate studies in obstetrics and gynecology, where she completed with high commendations. Dr. Bridgewater believes strongly in providing women with the best care possible, and as such has done further training in laparoscopy and cosmetic gynecology. Beyond her academic prowess, Dr. Bridgewater is also an advocate for women's health. This led her to be both vice chair and chair of the Junior Fellows of American College and Obstetrics and Gynecology, and she has presented at many symposiums locally and internationally regarding factors affecting women's health. Dr. Bridgewater used to work at the Victoria Jubilee Hospital, but her main focus now is on private healthcare, and she's currently getting ready to launch a women's wellness practice in Kingston. So look out for further updates on that. In her free time, she likes to travel and dance. I'm sure it's the soca. Please help me welcome your esteemed colleague, Dr. Kiri Bridgewater.
Just before Dr. Bridgewater begins, just want to say if there's a driver of a Pajero, Black Prado, license plate 2849 GJ, your windows are down, okay? So repeat, 2849 GJ, your windows are down.
Good morning, everyone. I hope everybody is feeling good and everybody's refreshed after the coffee break. Thank you so much, Mr. Freitas, for that introduction. And with no further ado, I will be going into my presentation today. I will be presenting on STI treatment and management. We're going to be talking about some of the things that are old, some of the things that are new, and what are the current best practices. Sorry. So this is the disclaimer. This presentation is based on publicly available information, and that information included is related to non-Novartis products, as well as non-Novartis approaches. The opinions issued here are from me and not necessarily a representation of Novartis' opinions. These slides are for educational purposes only and for the personal use of the audience. These slides are not for distribution outside of the aforementioned purpose without the approval of myself and Novartis. The contents of these slides reflect the best knowledge that I have at this time, at the time of the production and me giving it. And I declare to not have any impediment, or conflict of interest at the time of this presentation, which means that it has full rights and power authority to execute the services contracted by Novartis and my individual professional capacity, and not as an employee or agent of the public. So let's talk about this presentation. What are we going to be talking about? Well, it's STI treatment and management. So firstly, we have to define what are STIs. We're going to be talking about why is this important? What's the burden of disease? What's the relevance in our clinical practice? Why should we care? We're also going to talk about prevention, because we know, especially in more recent times, and rightfully so, preventative care is really where things are at. The truth is prevention is definitely better than cure. And if we can educate and change lifestyle change, well, institute lifestyle changes for our patients in a partnership, that can help them in both the short and the long term to avoid both acute situations as well as chronic complications. We're going to be talking about treatment regimes and if there have been any changes in recent times. And we're also going to talk about whether there's a need for post-treatment management. And if so, what is it? So firstly, this definition, just in case my mom's logged in somewhere, I didn't come up with this, right? Because she taught me to never define the word with the word. But this is actually the definition from the CDC 2021 guidelines, right? That the term sexually transmitted infection refers to a pathogen that causes an infection through sexual contact, whereas a disease refers to the recognizable disease state that has developed from that infection. So sexually transmitted infections have a profound impact, both sexual and reproductive health, but I dare say even more so. It can affect mental well-being, psychological well-being, as well as social implications as well for the patients. They are clinically relevant because they're so prevalent. These are the information and statistics from the CDC and the Center for Disease, right, as well as the World Health Organization. And these statistics are predominantly based on US stats, but that's really because there is, unfortunately, a lack of local statistics on this topic in recent times. However, they found that there are roughly more than actually 1 million sexually transmitted infections acquired every day worldwide. Every day is the statistic, 1 million. The majority of which are completely asymptomatic. So these are 1 million people getting infected with no inclination at all. And these things, as I said, can have repercussions. In 2020, the WHO estimated that 374 million new infections of the one of 4 particular STIs of note, chlamydia, gonorrhea, syphilis, and trichomoniasis. They found that more than 490 million people were estimated to be living with genital herpes in 2016. And it's estimated that 300 million have HPV infections. These are glaringly large numbers. Hence why this is very important, especially for first contact persons, especially for general practitioners, especially for primary healthcare personnel. So, as I mentioned, STIs can have serious implications. Yes, there's the physical, the immediate short-term implications. So, what the patient presents for, because sometimes they are symptomatic. So, the discomfort, the vaginal discomfort, the burning, the itching, what the case may be. In some cases, the abdominal pain, the nausea, the vomiting, depending on how severe the infection is, can have emotional implications, especially when the diagnosis is made. How patients feel about themselves and their self-body image when they've been diagnosed with an STI has significant ramifications. I'm sure you've all had it, patients cry in your office when you tell them that they've tested positive. Or they come in, you tell them they have to come back for the review of the results, and they already come in jittery, nervous. Doc, just tell me, just tell me. That's trauma, that's emotional trauma for patients. And if we can try to avoid that for them, or help them to avoid it, it is in both ours and their best interest. It can have mental health effects, especially when patients are diagnosed with STIs that technically are not curable. I've had patients diagnosed with depression, subsequent to an STI diagnosis. I mean, the one that jumps to us is always like HIV, but the truth is even herpes is sometimes a very difficult diagnosis for patients to come to grips with. They think about, you tell them, oh, you know, it's very common. Yes, but why me? When they think about going forward, especially if they're not in a committed relationship and they now have to think about what is their sexual future, having that conversation. Do they have that conversation? Do they not? How do they toe the line? How do they not have the business out in the street? You know, that weighs on patients mentally, physically, and social implications. A lot of these illnesses, sometimes they're not, sometimes, yes, it can be contracted within the relationship, and it can bring to light some infidelities, and that can have social implications to their social structure within their relationships. And in some cases, it's not even like that. Some cases, these are long-standing infections that are now being diagnosed because the patient wasn't doing screening before. But then how do they explain that to their partner? How do they convince their partner of that? Some of these tests don't give you short-term, long-term infections. So when they now have to have that conversation and take that prescription or advise their partner to go to the doctor, how do they navigate that? That has serious implications. Not only that, but it can also have long-term complications. And of course, the one that jumps out to our mind is fertility first and foremost, right? Especially me as a gynecologist, right? But there are other things. So having certain STIs can put you at risk for other STIs. How concomitant infections are very prevalent. It can also cause pregnancy complications. Of course, I have to put that there, right? As well as neonatal complications for my pediatric colleagues as well. In some cases, it can cause cancer. I mean, we know about HPV and the link with cervical cancer. We know about hepatitis and the link with liver cancer, cirrhosis, things like that. It can also cause cirrhosis, yeah? So STIs are significant in terms of the number, in terms of the effect, both short and long term. There's several types of STIs. I mean, honestly, we have the obvious ones, the chlamydia, the gonorrhea, the trich, you know. We have the syphilis, the hepatitis, which has become more topical in recent times. We have the HIV, which I mean is always prevalent and always worth discussing. We have some of the old school ones that kind of pop up every now and then, the ones that, you know, you kind of bite your tongue trying to say, like the lymphoinguinale and LGV, and I'm not gonna attempt to remember what that is right now, right? So STIs are a very, very long list. We cannot cover them all. Feel free to ask for part 2, Sandoz, but we cannot do it today, all right? So for today, I'm going to be honing in on certain topics and certain things that I thought would be one of clinical significance given the populace in terms of general practitioners, etc., but also the ones that I think have had the most recent changes, so that we can make sure that we're all up to date and abreast with how to manage these things. And the ones that we're going to be talking about today are chlamydia, gonorrhea, trichomoniasis, mycoplasma, PID, of course, we have to touch on that, especially as a gynecologist, and as well as my personal pet peeve, or my personal favorite, human papillomavirus, because I do want us to remember that HPV is a sexually transmitted infection, and we also need to be playing our part in preventing HPV dissemination. So in terms of STI prevention, as I mentioned, prevention is always better than cure. And the CDC says that the prevention and control of STIs are based on 5 major strategies. So firstly, risk assessment. You won't know who you need to be treating how unless you do a risk assessment at every visit, whether it be a young person, whether it be an old person, whether it's a man or a woman, you need to be doing risk assessments on these patients. And so that you can counsel them and avoid STIs by advising them on how to change their sexual behaviors, and also to give them recommended preventative services. You need to also consider vaccinations, right? In particular, of course, we're going to talk about HPV vaccination, as well as there are also types of pre-exposure vaccinations as well. We also need to identify those that are possibly with asymptomatic persons or people that have symptoms associated with STIs. And most importantly, is just as important is effective treatment. So making sure that we have effective treatment, counseling, follow-up for infected persons, and evaluation and treatment of the sexual partners that they have, the partners of those who are infected with the STI. This is the 5 paramount parts according to the CDC. So when we talk about risk assessment, we have to talk about the sexual history. A sexual history should be taken at every first contact assessment of a patient, and it should be repeated at intervals. A lot of times we kind of shy away from it because sometimes you feel uncomfortable by it, but you have to, because if you don't delve into a sexual history, you won't know the patient's risk profile, and you won't know how to best serve your patient, how to best assist your patient to have the best reproductive, mental, physical, psychological health that they can have. You have to ask the tough questions, but the questions don't have to be tough. The first thing I recommend is that we have to assess ourselves. We have to assess ourselves and our biases. We have to assess our thought process and make sure that we approach every sexual history conversation with as neutral an outlook as possible. We all have our personal belief systems. However, it is important that we do not directly impose that on our patients. This is a point, because I, as a physician, and as a Christian physician, I like to think of this as a time to show my Christianity through my actions, not necessarily directly through my words. So this is a personal thing, right? I do not impose my beliefs on others, but I show grace and understanding to everybody, regardless of your presentation, regardless of your belief system, regardless of what your orientation, your sexual, gender identity, sex, assigned sex, you know all the terminologies, right? We live in a time now, right? Yes, because there are distinctly different things right now, right? We live in a time where the variations amongst us are great. They're great, and they're becoming more and more visible and despairingly so, right? However, as physicians, we are there to do no harm, right? And that is not just physical harm, but my belief is that it's also emotional harm, right? So while you do not have to advocate or accept or, whatever person's lifestyle choices are, it is important to try and not scar that person throughout your process. And if you feel like you're not capable of caring for that person, it is best you refer. It is best you refer that patient than to deter that patient from the health system altogether. That's my personal opinion. That was not the CDC, okay? But they do say that you need to risk assess yourself, and you need to do your unbiased check to make sure that you are not imposing your biases on any of the patients, especially because CDC is an international organization. Thank you, organization. So they also have to be very, 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 very mindful of the LGBTQ plus society and community. All right. Secondly, when you're having your sexual history, another important thing is to be respectful and to establish rapport. I personally don't delve into sexual history right away. I do a lot of banter before. Even if the patient comes in with a vaginitis, I will go and talk about past surgical and allergies before I delve straight into the sexual, just because I don't want it to be seen by her that I'm looking at the sexual as the direct reason for it, even though it can be a concomitant thing. Additionally, establish rapport by sometimes, this is just my personal, sometimes just ask about something current. And I know sometimes when you have 100 patients in your clinic or your office pile up, you really can't take the time to sit down and get to know their mother and their grandmother, and if they have grandchildren and things of that nature. But just a one-off comment, just to lighten the mood. I mean, if it's a young person, sometimes like, you went to the Protégé concert, I mean, if it's an older person, I'll typically say something about something socially. What a way to, like these people watching Money Heist and want to shoot up these trucks all of a sudden, Boy, this can get out of control, You know, just a little light banter, just to lighten the mood, establish rapport, get the patient relaxed, you know, let their guard down a little bit. Additionally, when going into the actual sexual history, non-judgmental, keep your poker face at all times. Keep it light is my general thing at all times, right? Be empathetic to them in terms of how you communicate and use open-ended questions. So instead of saying, so do you have sex with men or do you have sex with women? You could say, oh, but these are serious things. You could say, what gender is your partner? Something a little bit more open, right? But letting you, just indicating that you know it could be one of different options, but making it less pointed of a question. Yeah? I know, right? What a day, what a day, what a time to be alive. But yes. So yes, asking questions like, how many partners, you know, are you currently sexually active? What kind of, you know, how many partners do you have? It's kind of one of those that you can't change, but you know, what gender are your partners? Pardon? What do you identify as, right? Depending as, you know? So instead of saying, are you a she, her, or they, them? You know? But these are the pronouns. These are the pronouns, right? And persons are very particular about being, sorry. All right, guys, I love that you're getting involved in the conversation, but can we have one conversation, please? But yes, these are the pronouns that are being used, but instead of being pointed, ask openly. How would you prefer that I refer to you? Especially if you get an inclination that it's not the standard, right? But don't make any assumptions. Ask everyone. A sexual history should be asked to everyone. Do not assume just because Miss Gwendolyn is 74, she's not sexually active. Please to ask her, because I hope she is. But it's good for your mental and everything, yes. All right? Do not assume that just because somebody is 14, they're not sexually active. It goes in the other way as well. And I know that that's when it can become a little prickly, especially when parents are present, as they should be at the age of 14. Again, open-ended questions. Have you been having any, do you have any concerns about your body? Do you have any sexual inclinations? Don't come out and be like, so you're having sex in front of the mother. You're gonna get one answer and one answer only. Precisely, right? Are you a virgin? No. No, but the truth is, this is what a lot of us, and this is just for us to grow, you know? Because innately, even me, I go, ooh, when you ask me that question, you know? And I'm sure everybody feels that way, you know? It incites a certain type of response, and you're not gonna get the accurate information, which means you're not gonna be able to risk assess, which means you're not gonna be able to provide the kind of counseling, which means you're not gonna be able to provide the kind of care, which means you're not going to help that person. Yes? Okay, so prevention. As I mentioned, so the sexual history, there are 4 Ps. You want to be talking about partners in terms of number, type of partners, etc., right? Because depending on the type of partner, whether it's men having sex with MSM or WSW, which is men who have sex with men and women who have sex with women, certain infections will become more prevalent, right? You want to talk about how many partners they're having at a time, right? You also want to talk about practices. So are they having only consensual sex? You want to talk about if they are co-using alcohol or drugs at the time of sexual activity. You want to talk about their protection level. Are they using a barrier form of protection, such as a condom? If they're not, if they're also doing pregnancy prevention. And you want to talk about their past sexual history in terms of sexually transmitted infections. Were they ever diagnosed with anything before? Was their partner treated at that incident? Were they rechecked if necessary? Because do they take their medication when they got treated? Because all of these things can have implications on their current clinical state. And you also want to do prevention counseling as well, right? Prevention counting speaks to vaccinations. So things like HPV vaccinations, depending on the situation, sometimes hepatitis vaccination, adjusting their sexual practices, right? Advising them on ways that they can decrease their risk for sexually transmitted infections. So decreasing their number of partners or using methods, barrier methods of protection as well. And the need for potential prophylaxis depending on their partner's status, etc. So let's talk about the actual infections now. So chlamydia. Chlamydia is a big one because chlamydia is actually the most frequently reported bacterial STI in the United States. And the prevalence is highest in women, in people that are less than 24 years old, less than and equal to. So this is your young, fertile population that you're talking about here, right? Most chlamydia infections are actually asymptomatic. So we have to have a low threshold for these infections, and we have to screen actively for this infection. The CDC recommends that all people under the age of, all women under the age of 35 should get screened for chlamydia at least once per year. So when the patient comes in, script through the nose and said, when last did they have a STI test? And that's regardless of if they've changed partner. Well, that's even if they have not changed a partner, they should get screened every year. Now, if they are having new sexual partners, if they have more than one sexual partner, if they have sex with concurrent partners at the same time, or a partner who has an STI, then the screening has to be adjusted as well. And you also need to take into consideration that chlamydia tends to be a co-infection with things like gonorrhea, HPV, and even BV. And so you need to screen for not just chlamydia. In terms of testing for chlamydia, PCR. PCR is king, right? Or for chlamydia testing. This can be done via vaginal or cervical or urethral swabs, or the one that may be a bit more socially acceptable, urine, right? Most of our patients we just send for urine. They have done studies that show that urine specimens are just as sensitive and specific as opposed in comparison to swabs. So you can use your urine specimen. However, it is advised that the urine specimen should be a first morning catch. So the first urine that they pass for the day. Sometimes I don't believe that's completely ideal in our setting because I think most of the labs just let them do it there on spot. I don't think they allow them to take home the containers. So we're not really testing as optimally as that, but the literature shows that that's actually the best detection rate. So perhaps we can look into that. Interestingly, when it came to swabs, they actually found that patient-done swabs and physician-done swabs had the same detection rate as well. So if you do want to do a swab, not sure why you prefer that one, but perhaps somebody can't pass urine. But if you do have to do a swab, you can actually allow the patient to do the swab themselves and not compromise your detection rate, all right? And that will allow them to feel like it's a bit more comfortable because that is innately a slightly uncomfortable thing, all right? There's no culture testing for chlamydia. It is only with PCR, and that is the gold standard. Fortunately, that is what we offer in our demographic as well. So in terms of chlamydia treatment, I believe this is on your pre and post test. Yes? Okay. Oh, hold on, have you guys done your pre and post test? Online, or the online are doing it alone? There's such a bias. All right, no problem. All right, so pre and post test. All right, so never mind then. So chlamydia treatment, the recommended, slide says that the recommended is azithro 1 gram PO stat, doxycycline 100 milligrams twice a day for 1 week. Everybody in agreement with this? Ah, the lone wolf. What do you disagree about it? Mm-hmm.
No, I've treated patients with that regimen and they have come back with the infection still in place. Mm-hmm. And I've had to double the dosage. Mm-hmm. Okay.
Understandable. And guess what? The CDC actually 100% acknowledges you and agrees with you. And they've changed the guidelines, unfortunately for us, slightly to state that azithromycin is actually no longer a recommended treatment. I am sorry, Sandoz and Benazit, but it is not the gold standard right now. All right? Yeah. I told you, something old, something new.
Could I just add something?
Sure.
In terms of the history, women middle-aged 30, 40 were having sex with younger men. A lot of time they come in with STIs. So we should inquire of the age of their partner, because a big difference in age group also contributes to a lot of STIs.
Agreed. So the current guidelines from the CDC's most recent updated recommendation is that we actually should not use azithromycin 1 gram as our go-to and first line for recommended treatment of chlamydia. I know that hurts a little inside because we really like it. We love supporting Sandoz with the Binazit, and it's easy, especially in our demographic where patient compliance is difficult sometimes. And the doxycycline does have GI effects sometimes. However, we have to think about what works. And what they've found is that azithro is not working as well. Simply, they're finding exactly what Doc mentioned, that when they retest, people have persistent infections. And especially in cases where patients have chlamydia positive, where chlamydia can have such deleterious effects on reproductive, especially for the women in the long term, in terms of tubal factors, infertility, etc. It is our mandate to try and provide the best. What I do is I counsel emphatically about how important adherence is. And the truth is, if I do see that they're really not going to do it, it is still an alternative regime on the CDC guidelines. So it's not to say that you cannot give it at all. It's just not the first line right now. So if you know in your heart that this is a patient that you see once every 5 years, they don't show back up, they only come when it's an issue, you barely caught them on this try, I'm not saying don't give them that azithromycin, right? If you know you're talking to them and the patient, because some of them will tell you straight up, Doc, I'm not take it, you know. I'm not take it. That one they sick me. The blue tablet? No, sir. Right? Because they know it. They know the Fletcher and they know the doxy by color, right? If you see that and you know, and they tell you clear as day, it's not going to happen, you do as best as you can for the patient and you give them azithromycin. However, if it is a patient and you know them, you have your patient that came into you because it is March and because she knows she does her annual testing every year in March, and you know that she has she's a responsible patient, she takes her sexual and reproductive health seriously, he takes his sexual and reproductive health seriously, and they will adhere, write the doxy over the azithro because it's going to give them better response, and just counsel them. And if you can, try to offset. If they know that they had nausea and vomiting the last time, try them on some gravel. Yeah? If you notice that the gravel makes them drowsy and they can't function in the days, try doxylamine. Unisom, doxylamine, the sleep tablet, is actually very good for nausea. And you try that also in your pregnant population as well. Very good returns on that. It's a once daily medication taken at night, and they sleep through the night like a baby and they feel and function better the following day. All right? So what are the alternatives? So the alternatives are azithromycin, so our Binazit, 1 gram Piostat, or you can use your levofloxacin, particularly your Sandoz levofloxacin, 500 milligrams once a day for the week. And then before, they used to also say erythromycin was another option that you could use. Yeah, we weren't using that anyway. But erythromycin has also been removed from the updated guidelines. Yes, seriously. Compliance is poor, drug resistance is high, it doesn't work as well. They've removed it. All right? So right now, your top line is doxy, and your middle ground agents are your stat azithro or your levo once a day. Now, of course, we'll have to talk about afterwards, because if we're having drug resistance, then we have to be more vigilant than we were before. It's not just, here's your prescription, have a good day, see you back next year. The CDC is actually now recommending that patients abstain for 7 days. So even if you give the start dose, you have to advise them to abstain from sex for 7 days. Right? They actually are now recommending retesting for chlamydia as well. You should retest for chlamydia in about 3 months after the infection to make sure it's not persistent or there's no reoccurrence or reinfection. Of course, we know that we also need to refer partners because these are sexually transmitted infections. So if your patient has it, her partner probably has it, or partners, depending on her choices. So you really should refer her patient, you should advise her to refer her patient, her partners for treatment. However, there's also an established role for what they call expedited partner therapy. And I know that this is going to be probably a little controversial. I tried to do a deep dive on what our laws around it are, but I did not see anything definitive. And what expedited partner therapy is you, the physician, writing the prescription for her partner at the time. Now, I know some people are of the opinion that, boy, I didn't see them. Is that, how does that work out for me? Allergic reactions, etc. But the CDC actually says that if there's a question as to whether or not the partner is going to go, or a question about if the patient is going to get the partner to go, depending on the situation, you should actually, it is in the best interest to do an expedited partner therapy and to write that prescription for them and send that prescription home with them. You're taking away one of the roadblocks for definitive treatment and clearance, all right? Of course, pardon? You can't, but you can only do what you can do. And at the end of the day, it is more likely that she's going to give them that prescription than, put it this way, her giving them that prescription is a one-step process. Them going to the doctor is her having to talk to them having to make an appointment, them having to physically go to the doctor. So 2 minimum, if you don't make an appointment and it's a walk-in, but a 2-step minimum process, potentially 3 steps. So we have no control over the outcome, but as I mentioned, we just do our best. I'm not getting into that. I'm not getting into that part, but yes. Well, that covers you medical legally, actually, because the prescription's in there. Somebody has a question, guys. Oh, yes.
Yeah. So if the patient that is in your office is a male patient, are you still going to do this expedited partner therapy, considering the fact that with the female patient, we do vaginal examination, and during your examination, you may see something different, like your approach may change for the female patient in comparison to the male patient, because what you're saying is if it's a female patient that came to you, you can write the prescription. I can imagine it working better versus when it's a male that came to you and you're supposed to write for the female at home. I don't know if you understand my question.
I understand the question, but what I dare say is if it changes, it would only change to add more. You giving her, so say he tests, sorry, and pardon me for always saying she, it's my go-to. That's my populace, right? But if you have a male that diagnosed with chlamydia, odds are his female partner has chlamydia. I said we're not, all right, you know what? Yes, let me be inclusive, yes. So, any partners, not just female, any partners that he may have will also likely have chlamydia as well, all right? Now, in the case of the female, which is the direct question here, she is now particularly at risk of sequelae, long-term sequelae, right? Yes, the clinical examination may have yielded other information. She may have BV as well as her chlamydia. She may have, one second, I just want to finish the question answer. She may have BV in addition to her chlamydia. She may have vulvovaginal candidiasis in addition to her chlamydia. But the staple is she probably has chlamydia. So treating her for that chlamydia is still going to save her from potential long-term sequelae. Yes, you may not get everything else that's going on with her, and that's why ideally her coming into the doctor's office is still the preference, but it still serves you better, not serves you better, but it still holds its importance and relevance to treat her for the chlamydia. Okay? Yes? I'm gonna have to.
Good morning. Riveting so far. Could you just, and this is a basic question I know, but could you please just highlight the salient features of the symptoms in both males and females?
Okay, so chlamydia, as I mentioned, is typically actually asymptomatic altogether. But when it does present, it tends to come with a urethritis type picture. So in the males, you're gonna have burning on urination, you may have frequency in urination, you may have like, especially some itching at the urethral meatus. They don't typically, sometimes they'll see a little bit of redness. They might say that, you know, they see a little erythema or redness or irritation at the urethral opening. In terms of long-term sequelae, if they do have complications, because they can also get urethral strictures. This is my limited remembrance of males, I'm just joking, yes. They can get urethral strictures. So that in those cases now, they will also present with things like their stream, their urinary stream being affected. They may notice that they have some post-voiding dribbling. They may notice that they have slower stream or weakened stream, where the stream is just going in different directions instead of their usual as well. In terms of the females, again, a lot of the urethritis type pictures, so the burning, the itching, the irritation, less so vaginal discharge. Most of the times the vaginal discharge is really a concomitant infection that's going on. So whether it be a little BV along with it, whether it be a little BVC along with it, but typically it's urethritis type symptoms in the symptomatic patients with chlamydia, all right?
All right, thank you.
Yeah,
I
they
think
can have cervicitis as well.
in the interest of time, we're going to ask us to just allow Doc to finish our presentation, and then we can go back to the Q&A.
Yeah, I'm not sure we're going to finish at this rate. But I like that you guys are so involved. So, of course, I have to touch on chlamydia and pregnancy, right? Because that's my area. This is the time when the Benazid does come in handy, because doxycycline is contraindicated in pregnancy. Right? So you cannot give it because it does have negative effects on the neonate. So in this case, you do go back for your good old faithful. They actually think that the alternative should be amoxicillin, right? Given in a TDS version for 1 week. And you should retest in 4 weeks and again at 3 months. This is a retesting schedule. And persons who are thought to be high risk at the time of their first presentation should be screened at that point in time as well. So persons who have high risk sexual behavior practices, at the first visit of pregnancy, you should also, in addition to antenatal screen, etc., you should also be screening these patients for STIs, because these STIs can have deleterious effects on the fetus and neonate, right? If it's not detected and treated in a timely fashion. I'm going to be moving a little bit faster in the interest of time. All right, guys? So that brings us to gonorrhea. Gonorrhea is our second big boy. It is the second most commonly reported bacterial communicable sexually transmitted infection or disease. There's a disparity in how gonorrhea presents. It actually tends to be more symptomatic in male and typically a little bit more asymptomatic in the females. That is what the literature has shown. They find that yearly screening for the at-risk population that we mentioned before, so those that are younger than or greater than the 25 years old, those that are older but have had change in partners, who have multiple partners, etc., should always be screened at least, at very least, a yearly basis. You should also be screening patients when they change partners as well, right? And of importance, they have also found that drug-resistant Neisseria gonorrhea is on the rise. So I'm sure you can figure out what that means. We got changes, all right? So in terms of testing, again, PCR is indicated and can be used, and it is an FDA-approved method of testing. But in the form of gonorrhea, cultures are also very pertinent, especially in a situation, because we're having multi-drug resistant gonorrhea as well now. Cultures are able to give you better sensitivity profiles. The only problem is cultures take a lot longer, etc. And with the culture, it has to be done by a swab, whereas you can do urine, etc. for the PCR, which tends to be a little bit more socially acceptable to our patients. In terms of treatment, right? I'm sure we all know this old one from before. Yes, I'm giving away the cat. This is not the current recommendation. Oh yes, gasp, yes, oh my. The 250 Don't picture it. Don't picture it. It's going to change. Right? 250 IM stats was a regime that we were giving before, and then we would always co-treat for the chlamydia because we know the two tend to go hand in hand with the azithromycin. So you already can decipher, because this is a very highly intellectual group, that clearly the azithro has to change now to the doxy, right? Because we've said that that's not the first line right now. But also the ceftriaxone dose has also changed. They have found that the serum levels that need to be acquired for clearance, 250 is not cutting it. They've actually increased it to 500. And it's weight-based. Yes, we're getting technical. So 500 milligrams IM stat is currently recommended. And that is if your patient is less than or about 150 kilograms. So you're looking at like 300 pounds-ish. 300 and change. It is a lot of weight, but there are people out there carrying it. I'm sure we've all seen at least once or twice, one or two patients that are above that weight profile, right? And so when we do, we have to make the adjustment, right? So in patients that are greater than the 150 kilogram, it is recommended that you actually just give them the whole 1 gram vial, right? So you give them 1 gram of Sandoz ceftriaxone, all right? Plus, of course, you advise them and try to get them to get the doxycycline on board. Again, if you have to, maneuver, then you can use the azithromycin, but the gold standard right now and the current recommendation is that of the doxycycline. It turns out if there's a penicillin allergy or a cephalosporin allergy or whatever, then you want to be using gentamicin is currently the recommendation, 240 milligrams stat dose, and then azithro, 2 grams, so it's an increased dose as the alternative. Now, again, because of the implications with gonorrhea, they are recommending that you abstain for 7 days after treatment. They are recommending that retesting be done 4 weeks, 3 monthly. And they are recommending, again, partner referral, and the role of expedited partner therapy is again advocated for in the CDC guidelines. Now, of course, you're probably wondering, it's an IM. How am I going to get the partner to get an IM without coming into office? Yeah, difficult. But what they actually recommend is cefixime, 800 milligram stat, and then you give the doxycycline or azithro as necessary for the chlamydia, ideally doxycycline. Now, cefixime is not something that I see in our pharmacies very often. They didn't give a lot of guidance in terms of alternatives thereafter. So in this case, I do think we probably would need to bring in the patient. I was looking for a comparison to see if cefuroxime could be used instead, but I did not see any clear guidelines or evidence that would support that treatment at all. So in this case, the cefixime is the recommended. If not, the partner needs to come in and get their intramuscular treatment as well. In pregnancy, again, serious neonatal complications if gonorrhea is undiagnosed. Again, it's the same regime as before because both ceftriaxone and azithro are safe in pregnancy. So good news, no need to adjust here because you've already would have adjusted for the doxy mentally, right? Again, you need to retest and you need to screen in high-risk patients. And they actually advocate for gonorrhea if you think it's very high risk to screen again in the 3rd trimester. Next one, trichomoniasis. So trichomoniasis is a very common STI caused by the protozoan parasite. The patient may or may not have symptoms. Of course, with trich, we're looking, typically these are going to be more vaginitis type symptoms when they come in. Patient comes in with burning, irritation of the introitus or the vagina. They'll typically complain of a discharge with an odor. When you look, you're likely going to see that frothy like discharge on speculum examination, okay? With the men, it can cause more of, again, urethritis because they don't have vaginitis. So, sorry. Yeah. Unlike gonorrhea and chlamydia, that is more common in your younger population, which is why the guidelines are targeted to the 25 and under 25. Trich is actually kind of universal. They don't see much of an age disparity when it comes to detection and diagnosis of trichomoniasis. However, they do find that women who have sex with women are at a higher risk of both trich as well as bacterial vaginosis. They found, interestingly, that lower socioeconomic groups tend to be at risk as well. Those who are incarcerated, those with BV, which may also go hand in hand with the WSW association as well, and that it causes an increased risk of cervical CA, interestingly, as well as complications in pregnancy, likely because of a co-infection with HPV. So in terms of trichomoniasis diagnosis, we focus again, PCR is king when it comes to STI, to be honest with you. When in doubt, request a PCR, right? You can also do a wet mount with trichomoniasis as well. However, I think that's less commonly done in our setting. PCR is typically what people will request, and it comes in your typical STI panel. So your STI 9 has trich. Yeah, the quad has trich too. Yeah, the quad has trich as well, right? Sorry, trichomoniasis, sorry. Right? In terms of the recommended treatments, of course, we know that metronidazole 2 gram orally stat, and then we all, used to love this one, and you have people that have the GI upset, tinidazole is typically the one that a lot of people, I think, now tend to veer towards a bit more. But unfortunately, they say no. Yeah, everything has gone wrong. The current guidelines, she's looking at me like she thinks I'm making this up. Google it. Right? The current guidelines based on the 2021 CDC rec release is that you should actually give the full 1-week course of metronidazole, because we are getting more and more resistance, reinfections. Pardon? Yeah, for women, sorry, specifically for women. Yeah, there's a disparity there. They found that the rates of reinfection was less in the men. And I think it has something, I think it is fair to extrapolate that it has something to do with our urogenital tract, perhaps, maybe our vaginal mucosa cells or something, because if you look at it, women who sex have women have a higher risk of it. And then the women tend to have harder time clearing it, whereas the men tend not to. So that men seem to be not as significant carriers of the organism. They didn't give a full, I don't think they've clearly delineated what it is about the women as opposed to the men, but there's a clear predilection for trichomoniasis towards women as opposed to men in terms of persistent infections and recurrence. And that's why the guidelines are that the women should be counseled and recommended to do a week worth, whereas the men can still get the start dose. Again, this is the current recommendation as first line. It is important that we look at what the patient is likely to do, right? I'm here to educate, right? So that we know what is the best practice, but we also need to take into consideration our profile and our patients and counsel our patients and risk assess our patients, right? So it's not to say that you can't give tinidazole, because it is still an alternative regime, but if you are, what I would say to take away from this is, if you do find yourself in a situation where you feel it is more beneficial to give the stat than the week course, try your best as possible to implement retesting. Yeah? Because what we want to do at the end of the day is to treat our patients as best as possible and clear the infections as best as possible. So even if it means you just give her a form to retest in the 4 weeks, right? Which is what I typically do. I give my patients the form at the time of treatment. I don't let them come back to get the form because then they think I'm scamming them, right? I just tell them, here what? I want you to feel better. So I'm going to give you this form and I want you to do it. And then I'll follow up with you, or whatever your best practice in your office is in terms of follow-up, whether you call them, whether you bring them back in at that point, whether you whatever. But I find that if you give them the form in advance, they tend to, and you explain to them the implications, they will feel more comfortable doing and following the protocol. Yeah? And you can tell them, honestly, I should be giving you a week's worth, but I know it's going to give you, or because you said you're not going to take this, I am giving you this alternative. But to protect you, this is the trade-off. You have to retest. And if you retest and you're positive, then we have to have another conversation. Yeah? Fortunately, metronidazole is perfectly fine in pregnancy. Therefore, there's no change when it comes to pregnant women, right? You just advocate for them to be compliant with their treatment regime, right? So the next one is mycoplasma. I hope you guys are still with me. We are almost there. I believe we are past the halfway mark. I'm sure they're soon going to start signaling to me, so I'll move faster. So mycoplasma genitalium causes symptomatic and asymptomatic urethritis. Those are the statistics. It can cause PID and infertility as well. It's one of the less talked about STIs, but I decided to put it on there because of the potential sequelae and complications associated with it. It is not in our quad. No, it is. It's in the quad. It's in the quad and in the S and the 9 panel as well. The recommendation was azithromycin or the doxycycline, and the alternatives were thought to be the emycin and the levofloxacin. However, yeah, I'm just gonna go straight to the current slide. The current slide is that they do doxy, right, instead of azithro. So generally, anytime you would have put doxy, try to move to azithro. Sorry, anytime you would have put azithro, try to move towards doxy for 1 week, okay? Same 100 milligrams twice a day, followed by the azithro. That is for people who have macrolide sensitive. This is based on your testing. For us, we don't really have that level of testing. We just get positive or negative, not macrolide sensitive or resistant. So I would recommend doxy followed by an azithro dose. Just assume and take that. Right, followed by 500 milligram orally once a day for 3 additional days. It is a significant change from the previous, right? But if you do have a patient that tests mycoplasma positive on your STI testing, this is the current regime to give. This is the standard based on the CDC guidelines. Right? In mycoplasma, they do recommend for abstaining for 1 week. Yeah. And they do not recommend testing. The partner treatment is a bit up in the air. The statistics are not showing whether it really is showing much of a clinical significance. And so as a result, the expedited partner therapy is not as clear as well. Right? PID, we all know about it. We know that PID is a spectrum of pelvic inflammatory disease or disorders of our upper female genital tract, endometritis, salpingitis, the gamut, right? We know that typically the STIs have been always pointed to whenever patients are diagnosed with PID, but they've actually been finding more and more STI negative PID patients. So we're finding more and more that BV and some of the other normal vaginal flora, when they become infections, can also cause PID as well, right? Gynecologia vaginalis, Haemophilus influenzae have all been identified in patients with PID. In terms of the take home for PID is always have a low threshold, right? And I'm sure this is something that has been said over and over, so we're all aware. If you're not sure, just treat, because the implications of not treating are so far reaching and can be devastating. And because PID can be such a spectrum from mild to severe, err on the side of caution and have a low threshold in these patients, right? The current regime has not, thankfully, changed much, except for the ones we've already established. So before you would have done chlamydia and you would have done azithro, 1 gram stat, now you're gonna do doxy, 500 for a week, right? Well, for 14 days in PID's case, right? Before you would have gone ceftriaxone 250, but we've established now for the gonorrhea, we're gonna go ceftriaxone 500, right? So it kind of flows with the previous changes, right? However, the newest change when it comes to PID, which I think most of us were doing anyway, is that flagyl is no longer optional. So before it used to be that, and then maybe flagyl, right? But now flagyl is a firm part of the plan as well. So metronidazole 500 milligrams. Oh, yeah, this is the outpatient. That's inpatient. Or orally, or yeah. So yeah, so you should give flagyl as well for the full 14 days. All right. If it is that they're in the hospital, which is less relevant to us in this clinical setting, but yeah, you want to be giving them the IV preparation when possible, even though the bioavailability is very similar, so it's not always a necessity. All right. They again recommend abstaining. They recommend retesting, especially if the patient was gonorrhea or chlamydia positive, and of course the previous statements already hold true. All right. Human papillomavirus, last but not least. Very important, please to recall, it is a sexually transmitted infection. Quite possibly the most common, it is the most common viral sexually transmitted infection, all right? Remember that there are over 150 types and that it can have significant, it is mostly self-limiting and asymptomatic, but when it is not, it has serious consequences, right? Almost every person that is sexually active will come into HPV at some point in time in their lives. What happens will vary from person to person, which brings to us the importance of vaccination. Please, vaccination should be encouraged. It is ideally in that 11 to 12 years, I said, but it can be given as early as 9, hence why the protocol locally is 9 to 11 years, right, for the institution vaccination, please remember that there are different types of vaccines. There are ones that do just the cervical cancer, right? So you have your bivalent, you have your quad. Well, I think they've kind of taken off the quad off the market now to push us into the 9. So it's really now down to the 2 and the 9, okay? The bivalent will cover for some of your cervical cancer types. Your 9-valent will cover for a few more of the cervical cancer in addition to your genital warts as well, all right? There. Of importance is where I find most discrepancy in information. You can give it up to 45 years. Yes, it is recommended up to 26, but it can be given. And in our demographic where cervical cancer is so prevalent, where our women are not getting screened, where HPV is very rampant and adenocarcinoma is more popular than squamous in when you compare it to other developed countries, I think we should be very lenient when it comes to that, okay? Yeah. All right, and regardless of whether or not they've had exposure to HPV in the past, please still recommend vaccination. Actually, I even push vaccination even more in my abnormal pap smear population, because that means they already have a likelihood to just hold on to it. And if you can, yes, they may have already been exposed to 1 or 2 strains, but if you can protect them from other strains, it still has benefit. And the side effects from the vaccine are so few and far between that to me, the benefits far outweigh the risk, all right? And of course, symptom treatment, if you have warts, remove them. You can use chemical topicals, or you can have cryotherapy, etc. And if anything else, send them over to us. We'll do colposcopy and get that sorted out, okay? So in conclusion, right, sexually transmitted diseases are very common, and although most are asymptomatic, they can have serious effects. We need to be proactive in assessing our patients' risk and diagnosing the conditions. Because of drug resistance, treatment recommendations are changing, and we need to keep abreast and current with our guidelines. And we need to counsel our patients appropriately and emphatically, right? Prevention is better than cure. So partnering with our patients to change their risk profile is very important and cannot be overstated. So I thank you for your time. These are some of my references.
All right. Dr. Bridgewater, we want to thank you for such an informative presentation. I know that you raised a lot of eyebrows today. In the interest of time, I'm going to take one question from the audience, but with your permission and the Agpj, for other questions, you can field them online. We'll send them to you and we'll ask for a response and we'll get it out to you, all right?
Good morning.
Good morning.
Thank you. I really enjoyed your presentation.
Thank you.
But this question now is for everybody here, but especially for you, because I would like to hear your opinion. So, regarding the HPV vaccination, right? It's recommended to be given within 9 to 11 or 9 to 12. Why isn't the vaccine given to both genders?
I think that's just a cost-benefit ratio in our country.
Okay. Regardless of that age group, right? We as adults, why aren't men also getting the vaccine, not just to protect themselves, but to protect their partners? Because it's important.
Agreed.
Right? So why does everybody just say, oh yeah, women should, both of us should, right? So why isn't it mentioned?
Agreed. 100% agreed, 1,000 times agreed. In terms of an institutional approach, especially with the government of Jamaica rolling out the vaccination in the school for the 9 to 11-year-old girls only, as I said, that's a cost-risk benefit. I think they just looked, and even internationally when they do the studies, they showed that yes, the ideal thing is to vaccinate both genders, but they found that because HPV infection has such higher incidence of complication in women, so 100 women and 100 men get HPV, get HPV. This is just a random stat, just to show the thing, right? 60 women may end up with an abnormal pap smear, and another 30 may end up with cervical cancer. Whereas of the 100 men, maybe 2 end up with penile cancer, and 1 end up with that. No, so that's why they look at it like that. Additionally, but there is the point of transmission, and if the man has it, you'll still end up infecting the woman. Understood. But if you have 100 vaccines to give out in your country, a developed country, huh?
Wow.
No.
Oh, okay.
Pause. I agree that the ideal is to give both, but I'm just saying that from a cost-benefit ratio, because the women have a higher incidence of complications, they aim to focus on the women. Personally, because you asked me my personal opinion, I vaccinate both. I say no to no man or woman. If I will, that's the only time you'll see I'm pregnancy. Men come into my office for vaccine all the time. Because when I talk to the women, I do talk to them about their partners getting vaccinated. But that is at their expense. The government have to factor in a lot more factors. I can give it to you if you're willing to pay for it. That's not a problem. And I will encourage you to take it. And we can all encourage them to take it because it has been shown to have benefit. But when you're looking on international guidelines, when you're looking at institutional recommendations and government recommendations, how there's always going to be a cost-benefit ratio to it. And when they assessed it, they thought it would be better to focus on the women. And that's the answer. Justice. Mm-hmm. To get it, correct. Mm-hmm.
Hello, just as they... Just a note of information, as a public health practitioner for Jamaica, just to say that the Ministry of Health has approved the HPV vaccine for boys, adolescent boys. It has been approved. This year, it was approved.
Well, I am very happy to hear that.
I would suggest that you contact your local medical officer of health, for it has been approved.
That's awesome.
Dr. Bridgewater, thank you so much. Excellent presentation. All right, still a lot more to discuss. And again, for persons who still have questions, you can send them in the chat and we'll ensure that the answers will come to you via email. So we know there were much more questions. We will answer them. We'll have Dr. Bridgewater, Dr. Christian, Dr. Soyibo answer them, and we'll send them in an email to you at a later date, all right? So at this point in time, I'm going to ask my esteemed colleague, Ms. Sashane Francis, to come and give the introduction for our next speaker, who will be speaking to us on pain management in motorcycle injuries. Please welcome Ms. Francis.
Thank you, Christopher. Greetings to all medical professionals, colleagues, special guests, and support staff. It is my pleasure to introduce our final speaker for the afternoon. Dr. Carrie Fletcher is an orthopedic consultant and academic coordinator for resident training in the orthopedic department at the Sandoz Bay Hospital. He is also the injury advisor to the National Road Safety Council, where he provides data which serves as a guide in their motorcycle training program. He is the author and co-author of over 25 publications and have reviewed 31 manuscripts for the British Medical Journal, the International Journal of Injury, Control and Safety Promotion, as well as the Asian Journal of Orthopedic Research. He has been team doctor for the National Beach Soccer team at their FIFA CONCACAF World Cup qualifying tournament, as well as team doctor for the Reggae Boys. His memberships are with the Jamaica Orthopedic Association, the Jamaica Medical Doctors Association, Caribbean Association of Neurosciences, and the Medical Protection Society. He is dynamic, multidisciplinary, and serves in many capacities as he continues to contribute to the medical fraternity and to the Society of Jamaica. Please help me to give a warm welcome to Dr. Carrie Keith Fletcher, who will be presenting on pain management in motorcycle injuries.
Good afternoon. All right, so as you heard, I'm going to be presenting on pain management of motorcycle injuries seen at the St. Anne's Bay Regional Hospital. Okay, so that's a disclaimer that despite the support that I've received from Sandoz, everything that I'm going to be presenting is either based on my research or my personal opinion, and therefore there's no external influence from Sandoz. So in this presentation, I'm going to cover an introduction to motorcycle injuries, and that's inclusive of fatalities. And then I'm going to segue into the motorcycle study itself, and then lastly, cover the analgesic issues when treating these injuries. So, no surprises here. Riding a motorcycle is very dangerous. In fact, some authorities say it is 4 times more dangerous than traveling in any other form of motor vehicle. There is some literature that will quote it as being 6 times more likely to cause a death as opposed to a motor car. This is particularly so because it offers no external protection for the driver or passenger. And this is particularly so because it is less stable, and this is especially so when executing an emergency maneuver such as swerving and sudden braking. As a result, wearing protective gear is of utmost importance, and the study that I will be presenting later, you will see that most of the riders were either totally unprotected or inadequately protected. And so, the analgesic demands of all of these people will be significantly high. Great for Sandoz, poor for the nation. So, when we look at motorcycle fatalities over the years in Jamaica, between 1992 and 2012, we then had an all-time high of 49 motorcycle fatalities in 2009. This then spiked to 65 in the year 2014. And then the following year, there was a subsequent 71% increase in fatalities. And this corresponded with a quadrupling of bikes that flooded the market, particularly in the western end of Jamaica, between the years 2012 to 2015. We then had an all-time high of 163 motorcycle fatalities, correlate that now to 49 in 2009. We then had somewhat of a dip last year at 142 fatalities, but note that when we look at all road users, last year was an all-time high of 488, up from the previous all-time high of 487 the previous year. So, motorcycle fatalities accounts for 30% of all fatalities amongst all road users for the past 5 years in this country, with pedestrians being in second place. It therefore is the highest category of all motor vehicle crashes resulting in fatalities, and the majority of them come from Hanover and Westmoreland. So this is why one of the major take-home messages to the government of Jamaica is the need to expand the formal training of our riders. I believe that it must be mandatory for all riders to be formally trained. What we have currently are novices on the road that are treating the motorcycle as a motorized bicycle, and their brethren or their uncle is teaching them how to ride. Now, this is particularly important when you consider that most of our injuries are preventable. Now, when Sandoz invited me to give this talk in 2019, the emphasis at the time, from my perspective, was that formal training was supposed to improve the skill of the rider so that they had the requisite balance, coordination, and precision in terms of execution of emergency maneuvers. Now that I've spent more time in the motor vehicle crash world, I've now realized that it goes beyond just improving skill level. It involves changing the mindset of the riders, changing the culture. When people are formally trained, they understand the importance of wearing protective gear. This should also be done in conjunction with getting a formal license as well as insurance. Now, license and insurance is something that I'm going to be presenting in the data later on, because I decided to look at this as a test of the roadworthiness of the rider as opposed to the fitness when it's looking at the roadworthiness of the vehicle. Now, another thing of note is that at the time of the study, a number of the motorcyclists admitted to me that they either did not do a formal road test or the road test was minimal in that they simply rode around in a circle. Some of them even went as far as to say, Doc, to tell you the truth, the man them afraid of bike, so them not going nowhere near it. So that is something that I have emphasized, and the Island Traffic Authority has revamped, they say, the road code and the testing, and you now have far more things to do in order to get a formal license. So once again, when I first gave this talk in 2019, a motorcyclist could simply get a learner's license and ride on that from now till forevermore. Now, with the new Road Traffic Act passed in February, they now have to, if they do not pass the road code at the end of a year, they will then have to renew it. Also, they now have to be accompanied by a licensed rider in the vicinity of about 6 meters from the motorcycle throughout their journey, thereby theoretically making it more difficult to just stay on your learner's license. The enforcement will be beyond the scope of this discussion. So, we've always had laws. As I mentioned, enforcement is another issue, as our helmet laws have been around from 1999. Now, not only are you required to wear a helmet, but there are certain international standards that your helmet must have, such as it must cover the entire face, you must have an adjustable visor, and a hard outer shell. Now, the old fines were $5,000, and now both the rider and the pillion passenger will be fined separately $8,000 if not wearing a helmet. Now, the electronic ticketing system caused a large furor amongst the taximen. However, the purpose of the electronic ticketing system is really to get rid of the old, cumbersome, slow means where the police officer would manually write up the ticket, and then there was a problem now getting the information to the tax office, the information to the courthouse. And so this is supposed to provide a real-time connection between the various agencies in the island. Now, you would have heard in the news several motorists, not only the motorcyclists, getting dozens and dozens of tickets, hundreds and hundreds of tickets. And the major problem there, well, one of, was the fact that the police had difficulty obtaining a warrant. And so they would catch the people, but they could not arrest them. So the electronic ticketing system is supposed to be, one, real-time, and two, more effective in terms of getting warrants for people's arrest. So other new laws, $10,000 for popping a wheelie. If you see carefully, that rider there is a gentleman named Sizzler Kalanji, who is rising to the occasion without a helmet. And $30,000 will afford you, that's the fine now for breath alcohol exceeding 0.02%. Now, speaking of alcohol, one of my references was a St. Lucian study in the West Indian Medical Journal, and they found that approximately 36% of their riders were potentially under the influence of alcohol at the time of crash. Most of the crashes took place on a weekend, which corresponded with when most St. Lucians imbibed their rum. Similarly, a Canadian study found a 30% rate of people who were potentially under the influence. Now you must be wondering, why am I using the term potentially under the influence? That is because neither study utilized a breathalyzer test, but both strongly advocated for its routine usage. I would like to also join them in this advocacy, and you will see a few reasons why. So this is not a situation that I have personally encountered. This is far more common in the parish of Westmoreland, but you will see multiple breaches of the law, multiple people at risk, multiple clients for Sandoz and their analgesic products. So in the year 2004, we had the Jamaica Injury Surveillance System. They looked at 9 hospitals throughout the country. These hospitals provided 70% of the island's elective admissions. They looked at 14,065 motor vehicle accidents across all of those emergency rooms. They noted a 19% rate of requirement for hospital admission. What's the importance of that? Because hospital admission, or the need for it, is a crude indicator of the severity of the injury. I would like for everyone to remember that figure of 19% when I present my study. I know it's not an MCQ. So of that total of 14,065, 8% of that total were from motorcycle crashes. When now the Jamaica Injury Surveillance System repeated the data 10 years later, motorcycle crashes now went from 8% to 15% of the total figure, and the total figure was greater than 14,065. So on to the study at hand. This study was conducted by the orthopedic department at the St. Anne's Bay Regional Hospital between March 2016 and June 2018. We saw a total of 155 patients, all of whom were male with the exception of 2 female passengers. All of the patients either went directly to the emergency room or they were referred to the emergency room from another health institution within the Northeast region. Other patients came from the orthopedic clinic. Also of note was that we had a pre-tested questionnaire, and so after informed consent, each of the patients gave data in the majority of times within 24 hours of being seen, and this was to reduce recall bias in the study. So we collected the data in real time in most cases, put it on an Excel sheet, and then my colleagues at the university campus had put this in an SPSS program for further detailed statistical information and analysis. So we see here that from the ages in the study range from 14 to 64 years of age, with a median age of 28. Now, of note, we see the patients in their 20s at 47% of the total study population, and more than 2/3 of the patients were under the age of 40. We only had 3 patients with chronic illnesses: a diabetic, an HIV positive patient, and a schizophrenic. So, of note, no, not on one bike, 3 separate motorcycles. So therefore, our study population for most practical purposes are young, healthy males, no cardiovascular issues, renal or gastrointestinal issues, so Sandoz didn't have to worry about side effects in these patients. So, this is an interesting slide to me. So this now looks at where the patient lives versus where the crash took place. So we see here, for example, in St. Mary, 25 people lived in St. Mary, 17 crashed in St. Mary. 7 people lived in Trelawney, 0 people crashed in Trelawney. So when we jump to St. Anne, 80 people lived in St. Anne, 113 crashed in St. Anne. So what does this tell you? People started their journey in their parish of origin, rode to St. Anne to crash their motorcycle. Absolutely. So 37% of people were potentially under the influence. What does that mean in this study? We simply asked, did you consume alcohol within 3 hours of the crash? Yes, I know this is not objective. Yes, I know that this doesn't mean that they were beyond the legal limit, but I will show you later on why it is that I think it's that important for us to push breathalyzer testing. So it is currently a pilot project in the corporate area, but they need to expand it. And between me and the audience, the results are somewhat disappointingly low in terms of their pickup rates. Now, kindly note also, in the months of December, there was a 50% and 40% rate of being potentially under the influence. As Doc here said, Christmas parties plays a role. Now, this photo I took while I was traveling in the hills of St. Anne. I just found it very fascinating. You had an unhelmeted rider, an unhelmeted passenger, but the helmet is protecting her rear end. Now, our accident frequency peaked in the last week of November in 2016, as opposed to the last week in September in 2017. Now, when we look at the timing of the crash, this metric now looks at the accident victim rate per 100 days. So we had 54 per 100 holidays a crash taking place, 24 per 100 on a weekend, and 14 per 100 on a weekday. But simply put, you were 4 times more likely to crash on a holiday as opposed to a weekend. And yes, I believe we're like our St. Lucian brothers, imbibing on the weekend and during the holidays. Now, looking at it regionally, now lower limb is defined as from the hip to the toe and upper limb from the shoulder to the fingertip. So we had a 55% injury rate in the lower limbs, 35% in the upper limbs, 5% each for the pelvis and spine, and a 31% head injury rate. Now, looking at the individual anatomical parts, this now shows that the leg leads the way, followed by the thigh and ankle, and the forearm leads the way in the upper limb. And this is in keeping with international data as well. So the lower limbs did not account just for quantity, but also quality. What do I mean by quality? Well, it accounted for the highest rates of admission and the highest needs for surgical intervention. Therefore, they were the worst injuries. So one of the major take-home messages that I've imparted at the National Road Safety Council is the need for our riders to wear lower limb protective gear in addition to helmets. So those are some of my recommendations. Now, I have given this presentation right in front of the Most Honorable Andrew Holness, and I saw all of the eyebrows frill, and I could see them thinking to themselves, how am I going to get the voter to accept this? It's not my business about the voters. I am here to give the injury recommendation. Now, this is my point of emphasis also. The shorts and slippers attire is very abundant. And this is one of our patients. Sorry for those who haven't eaten lunch as yet. You will notice a mangled forefoot, a mangled midfoot, and most of you probably have missed an ipsilateral femoral shaft fracture there as well. So I have appealed to the politicians, if you're worried about voters, at least ask them to wear shoes and long pants. So interestingly, an Observer article picked up on this study and the slippers that I've been talking about for a while. And this was, I'm not sure if you remember, a crash in Stony Hill involving 3 motorcyclists that died at the same time. 5? Okay. And these are the slippers from the site. So I don't think this has anything to do with the crash, but I am happy that they at least put it in the media. So as I mentioned earlier, the forearm is the most widely represented area in the upper limb. Now, when you look at an injury like this, we're now talking about an initial irrigation and debridement, a second irrigation and debridement, a third third one, putting in implants, possibly a fourth, irrigation and debridement, fifth, plastic surgical intervention, and God forbid if we get an infection at the end of our best efforts. So, multiple costs to the patient, multiple costs to the state. So, doing this study in real time allowed us to analyze the mechanism of injury in great detail. We found that almost half of the patients were involved in a collision with another motor vehicle. 40% almost was involved in some form of loss of control, where loss of control was defined as either speeding, riding on a wet road, or avoiding potholes, or a combination of the three. And errant overtaking, surprisingly, at only 14%. Now, the most important thing that I gathered was that when we meticulously scrutinized this data, without question, 80% were preventable, and another 79% maybe preventable, more than likely preventable. So we're looking at almost 9 out of 10 riders who, if they were formally trained, might not have been in this crash. So, we also found that only 29% of our riders were wearing a helmet at the time of the crash. And when we asked them why, over half of them, it was because they were riding for quote unquote a short distance. So, another take-home message which I have had them impart to their riders at the Westmoreland training facility is that we need to impress upon people that it only takes a second to be involved in a major crash. And kindly note that this is also applicable for seatbelts in other motor vehicles. Only a quarter of our patients had a license and insurance. And also remember what I said about the testing process of the license. Now, when we look at the decade by decade breakdown of who was wearing a helmet, yes, the teenagers led the way at 92%, but they account for less than 10% of the study population. My concern are the patients in their 20s at 81%. And a lot of these patients are the head of the household, head of the communities, and so when they're out for several months, the nation is impacted. And that's a further breakdown of the other decades in terms of helmet compliance. Now, the only thing I wanted to take from this slide is the fact that of those sustaining a head injury, 90% were unhelmeted. And only 3 out of the 155 riders were formally trained. And I have a surprise here. 1 is a Canadian tourist living in Canada. So statistically he counts, but in the context of the discussion, does not count. The second one is a police officer, and that was part of his police training. The third one is a Dover racer, and that's part of his training to be a racer. So the standard Jamaican citizen, none are formally trained. It's not accessible, as when I've inquired, I'm only aware of 1 training school in St. Anne, and I'm not certain about the quality as well. On a positive, last year, there were decreased fatalities in Westmoreland, where the motorcycle training school is. However, I am not going to be doing a victory lap because it is significantly underfunded, and I will not be surprised if the figure goes up next year. So I've been advocating for formal training for a while, and no, I do not know anybody at the Observer. Now here, I just want to zone in on the patients in their 30s, and 83% of them weren't wearing a helmet because of riding for a short distance. So for those who are in marketing, this is something that they need to consider. But of course, that needs funding, which is underfunded as well by the government. So, who was more likely to wear a helmet? So we found two things really. The older you were more likely to wear a helmet. And the larger the motorcycle, the more likely you were to wear a helmet. Now, the two are not mutually exclusive, as older riders tended to be the ones that rode the larger motorcycles as they came with more experience. But also, 75% of the motorcycles in the study were 150 cc's, which for those of the are uninitiated, those are very small bikes. So we had a disproportionate number of bikes that were small. So you were 3 times more likely to wear a helmet if you were riding a large motorcycle. And also of note, for those who had a license and insurance, the overall helmet compliance within that population was now 57%. And while that's not acceptable, it's literally almost twice the overall helmet compliance rate. So what does that tell you? Those who are not wearing a helmet don't have a license, they're not insured, so those who are taking risks are uniformly taking risks. So politicians always ask, what is the cost, what is the cost, what is the cost? The cost is beyond the scope of what my research group can do in a rural area hospital with limited staff and dedicated research resources. So I've done the best that I could with these following factors. So first one, employment rate. 88% of our riders were formally employed, and the majority of the jobs involved some form of manual labor. Now, how long were they admitted for? Half of the study population, 1 week or less, but that is not really an indication of severity. It's more those that typically we brought in for elective surgery and discharged the following day. Now, also note that the 2 weeks, greater than 2 weeks, that 20%, those are the ones that really will cost the government a lot of money. Now, also a little side note. This study was before COVID. Now, I don't know what the Kingston experience was, but I travel from Discovery Bay to St. Anne's Bay every day to work. And during the first 2 months of COVID, everyone's windows were up and each of the cars were socially distanced as they were petrified of catching COVID. Our hospital admission rate significantly declined during those months, with one exception: motorcyclists, our tried, true, and tested and loyal customers who love our treatment so much that they continue to come back for more and more treatment during COVID. They never stop coming. They continue to come at twice per week. 75% admission rate in the study. What was the admission rate when we looked at all road users earlier? 19%. So when we look at motorcyclists alone, this study picked up a 75% admission rate. So our riders earned between $7,000 and $50,000 a week at an average of $30,000 a week. And the cost of the standard motorcycle was $120,000. So basically 1 month's salary. Very affordable, very available. And so you can see when police seize the motorcycles, they are easily replaced. And I've also found out that sometimes the said motorcyclists buy back the motorcycle at the auction. So what are the independent predictors of admission? The number of body parts impacted speak for themselves. Alcohol. So 3 times increased risk, and 84% of those who consumed alcohol within 3 hours needed admission to hospital. So I am imploring the government officials once again, we need to do it better in terms of the breathalyzer testing. So need for surgery. Over half of the study population required surgery. And the areas that needed surgery the most, the thigh, the leg, the ankle. Now, just on a side note, you will see 100% of people with a wrist injury required admission. So this is where the statistics lie. So yes, that is true, but it wasn't the wrist that caused them to need admission. It was likely that they had a concomitant lower limb injury. So when ministers of finance spit out figures to you, take it with a grain of salt. The statistics can lie. So, on to pain. So we're going to discuss acute pain first, and the majority of these injuries would have fallen under moderate to severe pain, and it would have been mixed, a combination of both nociceptive pain and neuropathic pain, where nociceptive pain is as a result of tissue trauma in the periphery, and neuropathic pain is as a result of pain involving either the structural integrity of the nerve or the physiology of the nerve being disrupted. And yes, neuropathic pain has non-traumatic causes such as viruses, cancers, cancer treatment, but that's of course beyond the scope of this presentation. We also noted that people who were seemingly in minor crashes had lingering headaches, numbness, muscle aches, etc. And so getting on top of acute pain is of utmost importance. When we look now at where the pain centers are, the fibers travel in the sensory nerves either through the C fibers or the A delta fibers predominantly. Now the C fibers, which are unmyelinated, will give you this slow, dull, achy, difficult to localize pain. Whereas the A delta fibers are the myelin sheath, which are thicker, and we have the nodes of Ramsay in between. So you have saltatory conduction, which is much more rapid, and that's the pain that is readily localized by the brain. So looking further in the sensory pathway, once they go up those sensory nerves and they end up in the posterior horn of the spinal cord, that's where you find numerous cell bodies in the form of gray matter. Now, taking a more panoramic view of nociceptive pain, which I said earlier is one of the forms of acute pain, you have trauma in the periphery, and so you have damaged cells. Now, these damaged cells will now release numerous inflammatory mediators, inclusive of prostaglandins, serotonin, histamine, and bradykinin. Now, the prostaglandins will act on nearby damaged cells. So at the level of the cell membrane, where you have phospholipids, you will have arachidonic acid being converted by the COX-2 enzymes to prostaglandins. And therefore, you would then have an intracellular reaction with calcium being released. And then at the level of the nociceptor, you will have an action potential traveling along the pathway that I highlighted in the previous slides. Now, kindly note that there will be several nerves that will be affected based on the breadth of area affected. And you will have different levels of the spine at the same time being affected. So if this is maxed out because of inadequate treatment, you can then have peripheral hypersensitization, which can also lead to central hypersensitization at the level of the posterior horn. So we have to get on top of the acute pain quickly and early before it becomes chronic. Now, the take-home message from this is that after it passes here into the posterior horn, crosses anteriorly, ascends in the spinothalamic tract, and then passes through the midbrain and the thalamus, the brain then perceives the pain, and then you have an afferent pathway descending. Now, what we need for the treatment of these agents is multimodal therapy, 2 or more agents that will have a different mechanism of injury acting at different parts of the pain cycle. So acute pain will be a sudden onset lasting for a few days up to a few weeks with a specific cause such as those highlighted earlier. And as I mentioned earlier, we need to get on top of it early. Get rid of the cause of the pain, or else you will then get the chronic pain which develops slowly, and then the patient now will take much longer to recover. These young people will then take that much longer to get back to work and be productive. Now, this chronic pain can give you both physical effects, such as tense muscles, lack of energy, limited mobility, or emotional effects, anxiety, depression, post-traumatic stress disorder. It impacts your ability to enjoy pleasurable activities. So, when a patient comes to the orthopedic surgeon inadequately treated, we now have to also be a psychiatrist for this patient. And kindly note that patients with certain unhealthy behaviors, so they smoke, they consume excess alcohol, they're not very active, poor nutrition, these people are at increased risk of developing chronic pain. Now, nociceptive pain will also activate the sympathetic nervous system. So this patient now will present potentially with elevated blood pressure, tachycardia, rapid shallow breathing, and be diaphoretic. We can get a situation where, because of the platelet activation, which is part of the inflammatory response to the trauma, we then can get hypercoagulability with coagulation factors being brought into the mix. So as mentioned earlier, you will get chronic pain if you're not on top of the acute pain. This then will lead to reduced patient satisfaction and longer recovery. So one of the points of emphasis for nurses in general is that up to this week, I'm constantly frustrated whereby they tell you they did not give the pain medication because the patient said they did not have pain. We need to practice preemptive analgesia. I'm sure none of you here would want to have the pain and then get the pain medication after the fact. So with neuropathic pain, the nerve fibers themselves may be dysfunctional or physically injured. And so the brain receives mixed messages. Now, kindly note, not very prevalent in the study, but those who have pre-existing degenerative changes, whether this be wear and tear in the meniscus in the knee, whether it is wear and tear of the intervertebral disc, that patient population tends to have a higher incidence of neuropathic pain. So we have to be on the lookout, as the symptoms can be pretty debilitating, inclusive of pain, tingling, numbness, burning, shocking. Worse at night, it is very dramatic, very miserable when inadequately treated. So I mentioned that a number of our patients would have required multiple surgical procedures. The multimodal therapy will reduce the opiate demands of the patients and therefore lessen the likelihood of getting side effects of opiates, whereby they could get shallow breathing or they get very groggy or nauseous, and then the patient takes longer to be able to be rehabilitated and therefore longer to get back to work. So most of this I've mentioned earlier, and the co-analgesic is a group of agents now where the drug is not predominantly meant for pain, but it has pain relieving properties such as SSRIs and tricyclic antidepressants. We also have, of course, the non-opioids, the traditional NSAIDs, and the COX-2 inhibitors, as well as, of course, opioids. So looking at the opioids, we have acetaminophen and NSAIDs as the primary agents that we tend to use. And I mentioned opioid dose sparing effect when you utilize those agents as well. So you will reduce the respiratory depression and the addiction that so many people fear. Now, looking at celecoxib, as we all know, it's a COX-2 inhibitor. And the COX-2 is basically upregulated during inflammation. So once that is inhibited, you would then deal with the pain and inflammation. The beauty of it is that from a theoretical point of view, COX-1 is less inhibited. And of course, COX-1 is noted as the housekeeping enzyme, which amongst other functions such as renal and cerebral and cardiac flow, it is responsible for the mucus production and reduction of gastric acid secretion. So I like to talk about Cochrane review because this group of people, they meticulously scrutinize the literature. They look to see if drug companies are cheating. What do I mean by cheating? So you have situations where, I won't name the company, but celecoxib was used and they gave the patients aspirin and then claimed, oh, the cardiovascular effects were minimal. And then they gave another set of patients proton pump inhibitors and said, hey, our product does not cause gastrointestinal problems. So these people carefully look at how the patients are randomized, how they are controlled. So when they speak, I listen. So what did they say about celecoxib compared to other NSAIDs? Fewer gastrointestinal side effects compared to the other major competitors. They found it to be effective in terms of post-operative pain as monotherapy. And when they looked at 10 randomized control studies, they found that 400 milligrams of celecoxib gave you just as good pain relief as 400 milligrams of ibuprofen, but of course, with far less gastrointestinal side effects. Looking at atorocoxib, the Cochrane review, they looked at it as monotherapy as well, and they found that a single dose of 120 milligrams, and they put on probably 90 milligrams as well, will give you effective analgesia. They found that it gave you at least 50% pain relief in about 2/3 of patients with acute, moderate to severe post-operative pain. Now, what does that mean when they say high quality evidence? It means no matter how many times we look at it, no matter how many patients we use, no matter what dose of drug we use, we're not likely to change our mind. And also of note, they found that rescue medication was not needed for 20 hours, so thus justifying its once-a-day dosage as monotherapy. And as I said earlier, I'm not advocating for monotherapy. It just speaks to the effectiveness when used alone. And rescue medication also is another means that drug companies tend to use to cheat, where they will slip in another drug, they don't tell you, and they say, we give excellent pain review. So pregabalin now, excellent pain relief for peripheral and central neuropathic pain. Usual starting dose, 75 milligrams twice a day. I use this very, very heavily in my polytrauma patients. And I always combine it with an NSAID, and I found the effects to take place within a few days of commencement. 11 randomized control studies noted that you would have limited nausea and vomiting from the associated opioid usage. Tizanidine, excellent for neck and back pain, especially associated with spasm, as it is an excellent spasmolytic, and it's particularly effective in patients that have sciatica and other forms of radicular pain. When you use it, the NSAID requirements tend to be less, and so therefore, when you use all of these agents together synergistically, it reduces the overall likelihood of getting a side effect from each individual drug. Tizanidine, according to the Cochrane review, when they looked at ibuprofen and placebo and compared it with tizanidine and ibuprofen, the analgesic effects were similar, but of course, tizanidine and ibuprofen, less side effects in those patients. So in conclusion, multimodal therapy, multimodal therapy, hit them hard, hit them early for the first 1 to 2 days, and then, if anything, you can taper off. So non-opioid agents such as celecoxib and tizanidine will reduce the side effects of opioids. And these patients who are young, healthy, leaders in various forms, they need to get back to the work at hand so that our nation can move forward. So the raw data produced this paper, Predictors of Hospitalization and Surgical Intervention amongst patients with motorcycle injuries, as well as helmet use among motorcycle accident victims in the Northeast region of Jamaica, as well as this third paper in the Caribbean Medical Journal. So these papers, for those who are interested, are online and easy to find. Now, this is not a solo effort, so I'd like to thank those in the orthopedic department at St. Anne's Bay that helped me, particularly Dr. McLaren and Dr. Lindo, but of course the rest of the orthopedic team that helped me in different ways. Miss Robinson from the records department in St. Anne's Bay Hospital, the co-authors in my paper, and Kay Fletcher, who is at the back there, who helped me with the slides. Thank you very much.
Jennifer, let's follow a little protocol, please. Dr. Fletcher, I have it first. Wonderful lecture, sir. Just some comments I'd like to make in terms of pain relief, chronic pain relief. A lot of the patients who I see for medical legal reasons who are suing, most of their long-term complications are actually pain. Breathalyzer test. What's in your cup? I see you put an emphasis on alcohol, but a lot of persons who nowadays, they drink alcohol plus energy drink, and they're also smoking as well. So I think it's not just the breathalyzer. I think we need to look at the consumption of energy drinks and the smoking of marijuana and grabber as influences in terms of their abnormal behavior. Insurance payments. I totally endorse the need for protective gears. And I think this is something that the government, the road traffic, and the insurance company needs to look at, because instead of paying out a lot of these money to the persons who sue because they get injured, a lot of these motorcyclists, they get injured because they come up in drivers' blind side without very little warning. You're driving and all of a sudden they're in your blind spot. I think some of these monies, rather than go to the victims of accident, should be paid to the hospital to take care of them. And if we institute this sort of knowledge and practice in terms of paying out insurance money to the hospitals rather than to give these persons, probably they might just, drive more carefully, and probably the government might take it in terms of instituting this practice in terms of wearing protective clothing.
All right, thank you for your comments. I'd like to briefly state something on marijuana. So I don't remember the exact figure, to be honest with you, but it was almost half of the study population smoked marijuana. The challenge that I had with marijuana and why I did not present anything on marijuana was that alcohol, it was much easier to talk about cause and effect than marijuana. I could get certain symptomatology with regards to alcohol, whereas the marijuana, most of these guys are smoking throughout the day and multiple times per day. And so it was far more challenging. I would need objective testing. So marijuana testing is something that I have spoken about behind closed doors, but since I have no objective data, I didn't talk about it. However, I will have something to say about marijuana in the future. Hint, hint, Sandoz. I can't comment on it because I honestly did not think about it.
I was very keyed in to the non-opioid use because I find that the Americans have gone the way where opioid use, and I find that opioids do not address the site of pain. It fools the brain into thinking you don't have any pain. You understand? And then that's why they keep having to increase the opioids until they get to murderous doses. People just die.
And that's why they particularly have a problem with opioid overdosing.
I'm glad we are going to the way of the non-opioid drugs. And have you ever tried things like Tegretol for pain?
Yes,
the anti-epileptic.
Yes, I have.
Yes, and they work far more than anything. And funny enough, when they talk about Panadine.
Sorry, Tegretol is amitriptyline?
No.
Oh, well, I'm more use amitriptyline than Tegretol.
Which is for depression, like
Yeah.
an antidepressant, right? But it's epileptic.
Anti-epileptic, yeah.
Epileptic, right. But when they talk about Panadine, it is better you use 2 extra strength Panadol, which has 500 milligrams of Panadol in each, because the Panadine only has 350 and the opioid, which doesn't work.
My experience with opioids will mainly be pethidine in a hospital setting, and a lot of times a number of the patients say it makes them drowsy more than take away the pain.
Sorry, I have 2 questions. So thank you very much for that very enlightening presentation. I don't think I've done one of these in a while, so I'm glad that I stayed behind. So Carrie, 2 things. Maybe you did, but at least for the future, this is just my observation. Was there any difference in either pain perception, pain threshold for those persons who have been exposed to marijuana?
Absolutely.
And in which direction was it? Because we always have a debate about that.
So certainly, the people who are marijuana smokers tend to require higher dosages to get them controlled. I mean, I think the orthopedic population probably has the highest marijuana usage, anecdotally. And so it's something I've observed time and time again. And the anesthetists will then, if it's not in the docket, but they say, sir, you smoke? And so on. So a lot of them, they definitely require higher dosages to get them controlled. And then, of course, they then tend to get groggy thereafter, and they take long to wake up from the anesthesia and that sort of thing. Very, very difficult to treat.
And also, just follow up to that, what is the role then of using, well, I guess derivatives now as pain management for these patients? So they're already exposed to marijuana, they end up with chronic pain, God forbid. Mm-hmm. Would you still recommend the use of derivatives to control their pain, as it is being pushed for chronic pain like in the first world country?
I'm not in a position to make that recommendation.
Okay. All right. So in that study, was there any mortality?
Excellent question. In fact, I've always wondered how come nobody has ever asked me that. One person died.
One person?
One person died. That person had a cervical spine injury. If memory serves me correctly, C3, but I know for sure it was in the upper cervical spine. And we were in the process of transferring the patient to a type A facility. And he passed away. So I just want to add something before you ask the next question, that what this study indirectly shows you is that the mortality is mainly at the site of the crash. And so one of the things that I've been advocating for is toxicology screens as well, to see the contribution of alcohol and marijuana in the fatalities. Because one of the drawbacks in terms of the breathalyzer testing, and I've grown very impatient, sitting in meetings for 3 years and having the question unanswered about what is the rights of the patient. Is it assault if we do blood alcohol levels and so on? What does our Attorney General have to say? And we're going around in circles and circles, not getting the answer. I said, well, all right, then at least the dead person can't complain. So let us get the toxicology screens in them, and so we can determine cause and effect. I'm not going to comment on that. Because as I said, that's an ongoing thing that I'm tired of talking about, to be honest with you.
So my real interest in that is because you have a very healthy population.
Yes.
And if we're going to speak, just pardon me, about organ procurement and organ donation, in this case, you know, it's probably an area to look into, although, you know, your mortality is very, very low. Thank you.
They don't reach to the hospital.
Dr. Fletcher? Very vibrant presentation. Thank you.
Thank you, Nurse Gillens.
I'm concerned about where we will actually start doing the breathalyzer test, because you mentioned that most of the fatalities or the accidents would happen in Westmoreland, 40%, which is a high number.
And to cut you a second, 80% of the trauma victims in Westmoreland are motorcycle crashes.
Right. So I'm not sure if you failed to, because I listened to every bit of your presentation. I'm not sure if you failed to tell us, you know, what percentage of those who actually admitted to having had alcohol for the 3 hours prior to the accident, if they were from Westmoreland, or if there was a...
No, the study population, almost the majority of the patients were from the Northeast Region Health Authority. We had about 3 patients from Cornwall because of the whole refurbishing issues. So for 90-something% would be from Northeast Region, and the majority would be from St. Anne.
So why don't
So Westmoreland, there's nobody from Westmoreland here. And I have pointed out to the authorities that whatever data I have presented, it's worse in Westmoreland.
Right.
Yes.
So I know Kingston is Jamaica, but why can't we actually concentrate on where the problem is and do the breathalyzer?
That's where they've started. So there actually is a pilot study for the past 2 years in Kingston and St. Catherine. They haven't publicized it. And what I have said is that the pickup rate is disappointingly low. I don't want to really divulge further on that, but it's disappointingly low at this point.
All right, thank you so much. At this point, we have to come to an end. Dr. Fletcher, very, very informative presentation. We thank you so much. Very engaging. Oh, Dr. Bridgewater has a quick comment.
Sorry again, good afternoon. I think it's afternoon now. Yes, good afternoon, everybody. So thank you to Dr. Fletcher for that presentation, but I just want to update you guys because we got some very important information that I think some of you in particular will be very glad to hear. Breaking news, right? The ministry, as referenced earlier, is doing vaccinations for boys. They actually released an official, we have a copy of an official release that they did late last month. And starting April 1st, young boys between 9 and 14 will be eligible for the 1 dose. Those that are immunocompromised will be advised to get the 3-dose regime as adults do. As it stands right now, between the 15 to 26, it is still only girls, but I think we can infer that they are trying to diversify the use of the vaccine, and perhaps that will change in the future as well. so we can all stay abreast. And so now we know that we can send the mails officially, and that is something that is going to be disseminated amongst the group. So if you have any pushback or they're unaware, we can advise and implement so we can provide the best care possible. Pardon? Yes, free in the health centers, correct, yes. So Ministry of Health issued. All right, thank you.
Thank you, Dr. Bridgewater. Of course, you know that the Sandoz Healthcare Summit could not have been a success without our partnership with the Agpj, and as such, I'm going to invite Dr. Peter Swaby to give us the vote of thanks.
Well, I think you can agree this was an excellent summit, and okay. So I want to thank our sponsors, Sandoz and the Sandoz team, for making today's healthcare summit not only possible, but a great success. And to Mr. Beecher for being a fantastic moderator of today's proceedings. I want to thank our speakers, Dr. Christian-Shelton, Dr. Soyibo, Dr. Bridgewater, and Dr. Fletcher for clear, current, comprehensive presentations that did not go over our heads. To Dr. Donald Gordon, Lynn Thompson Hyatt, and the executive of the AGP for the bringing of their organizational skills and collaborative skills to executing an excellent program. To Allgate Solutions and Sam Heron for excellent management of our online and in-house presentations and the fielding of the questions. To Courtly Suites and their staff for providing the facilities and services that have facilitated our refreshment and social engagement. And to you, our in-person and online participants who make all this worthwhile. 50 in person, 1,000 on Zoom, and 250 on YouTube. Thank you all for your invaluable contribution to making today a resounding success. And why don't we pray for the food? Dear God, thank you so much for this food. Bless it to our bodies and help us to have a great time together. We pray in Jesus' name. Amen.
All right, thank you, Dr. Swaby, and thank you everyone for making this a success again. Lunch has been served. Please enjoy, and thank you.
We are experience. We are resilience. We are pride. We are Sandoz. We are professionals who research every day with passion to increase access to generic and biosimilar medicines that significantly improve people's lives. We are a team of people who develop greater access, offer more treatment options, and contribute to create more competitive markets. We are inspiration. We lead an agile, dynamic, and innovative pharmaceutical company throughout Central America and the Caribbean. We are pioneers. We are Sandoz, a Novartis division.